Namaste Madhuri madam, Sapani here.
Obstetric and Gynec Teacher Forum of India. This program was the brainchild of Dr. P.C. Mahapatra with the help of Dr. Ashish Mukhopadhyay. The main coordinator and convener for today's program is Dr. Arun H. Nayak, who is professor and head of department at Lokmanya Tilak Municipal Medical College. May I request our team to flash a CV of Dr. Arun Nayak, sir? Well, I have worked with him for a very long time, and I actually don't need the CV. But for everyone to see, he's a professor and head of department at Lokmanya Tilak Municipal Medical College. He's been the president of MOGS in 2015-16. He has an experience of his clinical fellowship done at Korea. He's a joint assistant editor at Foxy Journal of Obstetric and Gynecology of India. He's won several awards. To name few are Foxy Corion Award, the Hargobind Medical Fellowship for Overseas Training, the Young Scientist Award by MOGS. He's specially trained in laparoscopy and SUI surgeries during his fellowship at Korea. His numerous publications to his name and his special interest is SUI and NDVH hysterectomy. Welcome, sir.
Thank you, Madhuri, for that kind introduction. Good afternoon, Dr. P.C. Mahapatra. Good afternoon, my friend Ashish and Dr. Laul and my co-convener, Dr. Madhuri and Dr. Dipali. It's a pleasure to welcome you all for this new initiative, brainchild as mentioned by Dr. Madhuri, a brainchild of Dr. P.C. Mahapatra and Dr. Ashish. I know when we're doing post-graduation, our learning was basically during ward rounds. Dr. Laul was associate professor when I was resident in IR, and our learning was when we used to attend the rounds and whatever the questions were asked by our seniors, and we used to learn. There were very few concentrated programs which should tell us what are the exam questions, what are the minute points which are important when we are examining a patient. And we used to appear for our exams with whatever knowledge gathered by attending the ward rounds. So it's really heartening to know that concentrated efforts are made nowadays for giving knowledge, for training our newer generation and giving them a practical experience how exams are conducted and how they should prepare for the post-graduation exams. Mind you, this postgraduate exam is just the beginning of our long professional career. And if we make our base very strong, if we make the foundation strong, obviously our future career is going to be really good and it will benefit the women at large and society at large. So I welcome you all for this new initiative. Already we have conducted 4 or 5 programs like this, and I'm sure at the end of this program, all the PG students who are logged in today, they will benefit immensely. And I thank Dr. P.C. Mahapatra and Dr. Ashish for initiating such a great novel initiative. Thank you very much.
Thank you, sir, for those kind words. Can we have CV slide of Dr. Ashish, sir? I request Dr. Ashish Mukhopadhyay, sir, for a short address to our students. He's the principal, professor, and unit chief at CSS College of Obstetric, Gynec, and Child Head, Kolkata. He's a vice president, Foxy, 2016-17. He's the governing. He is the elected governing council member for ICOG 2021-22. Past president of Bengal OBGYN Society, ex-chairperson Medical Education Committee of Foxy, scientific chair AICOG 2022, and a WHO fellow on maternal health. Welcome, sir.
Madhuri Mendale, thank you so much for those welcoming words. Well, ladies and gentlemen, welcome to the 7th program of our Postgraduate Teachers Forum of India. As you heard, this is a unique initiative by our mentor, Professor P.C. Mahapatra. And we have come across the entire country in a clockwise manner. We started with the East Zone, where we inaugurated on a Teachers' Day program, 5th September, that was this program. Then we followed in the north, the south zone, then west zone, then north zone, then again it's zone, and then south zone, and now it is west again. So this is a 7 program, and I believe that with this program, we are going to reach our postgraduate students as well as the teachers in formulating certain principles of discussion of clinical cases and also lectures in order to clarify the gray zones in their minds. I have been associated with PG teaching for last 35 years, and from my experience, I've heard that a student is as good as he is taught the present day obstetrics and gynecology in a way which is acceptable to him or her. Frequently, what happens in our busy day practice, and also in COVID situation today, we are not able to reach the proper understanding of the subject. And I think that this kind of tutorial classes will help them a lot. And more than that, it will help us, the teachers, being encouraged and enriched with knowledge, because many students know better than us. And I believe that we learn till we leave. That is the reason, and that is why I respect this gentleman called Dr. P.C. Mahapatra, whom I called more a teacher, more a philosopher than a teacher. He is a philosopher, also is a teacher par excellence. Can I have his slide CV, please? Do you have this? Yes. Yes. It is useless attempt to introduce Dr. P.C. Mahapatra to the audience, because he is known everywhere, even beyond the boundaries of our country. But for the record's sake, he was a professor, Department of Obstetrics and Gynecology at SCB Medical College, Cuttack, a very favorite venue of myself, and whom I visited many, many times. And I was the person who was honored with the honorary membership sort of things in Odisha Gynecological Society. Most importantly, he proclaims that, and also he agrees that he is a satisfied soul as a teacher. But to me, he is a more than a teacher. He's a philosopher, a friend, and a guide in all situations of life. He's passionately involved on teaching undergraduates and postgraduates in obstetrics and gynecology since 1986. That is 36 years now, 34 years now. A postgraduate examiner in Kolkata, Guwahati, Mumbai, and Berhampur University, but that's only a few of them. He has traveled extensively across the length and breadth of the country. And the point that he keeps last in his CV is that he was the president of Foxy 2011. So with that, I would like to invite Dr. P.C. Mahapatra, our mentor, to say a few words and let the ball rolling in starting today's program. Dr. P.C. Mahapatra, please, sir.
Thank you, Ashish, for overestimating me. You love me so much that you have elaborated everything about me. I think I'm in the outset, I must congratulate all of you, all the faculty of the LTTM and Hospital, Mumbai and Siana Hospital, under the dynamic leadership of the teacher of teachers, no other than Professor Arun Naik, and the whole team and faculty of obstetrics and gynecology in this particular webinar and 7th episode of this OGTT Obstetric Gynec Teachers Tutorial, which is going on, as Ashish has rightly told, that I'm really happy that is doing very well, and postgraduates and the faculties are also benefited out of the programs for that. Well, again, I'm happy that Arun has done a good job in selecting a particular topic of uterovaginal prolapse with the stress incontinence. And I think with the lecture followed by that, 2 case presentations by the postgraduates, and that will be very much discussed by the externals and internals for that. I think this is the model which Ashish has already corrected it, and Ashish has really propagated this module and given it to this. Rightly, I again agree with Professor Arun Naik that the purpose of postgraduate is twofold. One is a passing of examination, and second most important is to build at the end of 3 years to make them a right professional who can deliver the goods after the exam and all that. So that is the main purpose of this particular program, where in our days we are usually learning from seeing from our seniors and rounds and all that. There is no clear-cut program for that. And I think today, with the expansion of knowledge and conceptual advances, our basic purpose is the clearance of the fundamentals. I think the foundation stone we must, as a teacher, give to the particularly students, because in this profession a mentor is necessary. You can do other professions without mentor, but mentorship is absolutely important in medical profession, and therefore the purpose of this particular ongoing program for that. I welcome all of you, Aparna, Deepali, and Arun, and everybody for that program, and all postgraduates viewing this program all over the country. And welcome everybody, and thank Arun and the team for initiating this in the 7th episode and targeting, so that many, not only the postgraduates will be benefited, but the faculty will be benefited at large. And that is the main purpose for which I think our purpose is solved for that. Thank you, Ashish. And Ashish, you have coordinated very well for that, and you deserve a special thanks from me, apart from other people, for that. Thank you very much, and I hope Arun will start the program under the other conveners for that.
Thank you, sir. Yes, Madhuri, please carry on.
Thank you, sir. Thank you, sir, for those encouraging words. Under the able guidance of Nayak, sir, it's really, your words mean a lot for us. We start with our program. Our first session is a talk on SUI by Dr. Aparna Hegde, ma'am. Our chairpersons for the session are Dr. Rajiv Lal. Please, may I have his CV slide? Yes. And Dr. Deepali Kapote. Dr. Rajiv Lal is president of Thane Obstetric and Gynecology Society. He's an honorary professor at the Rajiv Gandhi Medical College. He is director of Renuka Nursing Home and consultant OBGY for last 30 years. He's also a half marathon runner and an avid singer. Welcome, sir.
Thank you. Thank you.
Deepali is a dear friend and an assistant professor at Sion Hospital. She's also a managing committee member of Thane OBGY Society. I request Dr. Rajiv Lal, sir, to welcome and introduce our speaker.
Hello, am I audible?
Yes, sir.
Yeah. Thank you very much. This is an excellent initiative, this OGTT, that is Obstetric Gynec Teachers Tutorial, started by Dr. P.C. Mahapatra and Dr. Ashish. Thank you very much to them. And also, I know Dr. Arun Nayak from my days in Nair. So, thank you, Dr. Arun Nayak for inviting me. Today's first topic is on stress urinary incontinence, to be proposed by Dr. Aparna Hegde. May I now introduce Dr. Aparna Hegde? Dr. Aparna Hegde is an associate professor urogynecology, Kama Hospital, and grand medical consultant urogynecologist, also at Global Hospital Mumbai, Surya Hospital Mumbai, and also Women's Hospital Mumbai. And she is founder and director of Center for Urogynecology and Pelvic Health. She is founder and managing trustee of Arman, an NGO that works in the field of maternal and child health in 16 states and has impacted the life of over 14 million women and their children. She is member of editorial board, International Urogynecological Journal. She is member of International Urogynecology Committee Prolapse, member 7th International Consultation on Continence, board member of Foundation of International Urogynecological Assistance, principal investigator NIH grant on dysfunctional warding in adolescent girls. She has many awards, for example, TED Fellow 2020, then WHO Public Health Champion 2017. She is also one of the 5 women global leaders featured in Voice of America documentary, A Single Step in Journey of Women's Leader. So with this short introduction, may I now invite Dr. Aparna Hegde to give her talk on stress urinary incontinence. You have to unmute yourself. You are muted.
Thank you so much for having me here, sir, and thank you for the kind introduction. And I'm so grateful to give this talk in front of so many of my esteemed seniors and teachers. And of course, I am a Sion Hospital student. Before I went abroad to Stanford and Cleveland Clinic, it's always great to be called back by Sion Hospital to give a talk, on a subject I'm very fond of and is my, subject area. So let me just share my screen first, and then 1 second. Yeah. Yeah. Can you see my screen?
Yes.
So Got half an hour. Yeah. So we talk about management of SUI. So I'm assuming that we've really, evaluated the patient really, really well and come to a point that we have ruled out the patient has overactive bladder. That's extremely important, right? So you need to really understand the patient has SUI, and that is based on your examination, your history taking examination, and basic diagnostics, which I'm not going to cover in this talk because I'm going to go on to management. Hopefully next time I can talk about evaluation of an incontinence patient, right? So when you come out, talk about management, the first thing is weight loss, right? So, weight loss has been proved to reduce the amount of, SUI the woman has. They have to stop smoking, they have to treat chronic cough and UTI. That's the first step. Second thing is Kegel exercises, right? Extremely important that every woman who comes to the OPD with SUI, you're doing an Oxford score. That is, you measure the pelvic floor muscle strength. 2 fingers in the vagina, you ask the patient to squeeze, and you access her Oxford score, right? So Oxford score would be 0, no squeeze. 5 will be very good lift of the pelvic floor and lateral contraction of your fingers. And you will assess the pelvic floor and teach the woman how to do Kegel exercises. Now, Kegel exercises have to be done daily for 3 months, right? Basically. So that is an extremely important part of the treatment of SUI. Next important part of the treatment is amount of fluid intake, right? So 5 to 8 glasses of liquids a day is extremely important. Don't go beyond 8 glasses because only unnecessarily leading to her having excessive, voiding happening. And then when she's full bladder more often, when you cough, you're going to leak, right? So 5 to 8 glasses, all that you require per day. And then time voiding. So what happens is like a lot of doctors, right? So I had a patient from Patna, doctor, right? And all our patients of SUI, I'll make them undergo a bladder diary, the 3-day record of how much they drink, how much they pee. And when I saw her bladder diary, she had severe SUI and she had severe overactive bladder, right? Urgency incontinence. And what I found in her bladder diary was that she was going to the bathroom very, very, very late. A lot of us doctors get used to the idea of holding on urine because we don't have time to go to the bathroom. We delay voiding, and when we delay voiding, of course, if you cough and you're somebody prone to SUI, you're going to leak. So extremely important that we ensure that all women go properly every 3 hours, right? So even women with dementia, you have to put them on a proper voiding schedule. So these are the behavioral modifications you start off with. Next, extremely important is the Kegel exercises, right? I told you the pelvic floor muscle exercises. That's the first step in treatment. Now, when you do pelvic floor muscle strengthening, what happens, right? It does 2 things. One is that it causes regular strengthening. When it increases, your levator muscle is made of 2 fibers, type 1 fiber and type 2 fibers. Yes. Type 1 fibers are the fibers that are responsible for long contraction and long relaxation. So when I do my Kegel exercises and I strengthen the type 1 fibers of levator muscle, it leads to increased endurance and increased stiffness and structural support of the pelvic floor over time. But I also need to exercise my type 2 fibers. Type 2 fibers are the fibers which are responsible for quick contraction, quick relaxation. Now, when I, strengthen my type 2 fibers of levator muscle, I'm able to perform something called as bracing or knack technique. What is that? What happens is that once your muscles are strong enough, you train the women to squeeze quickly before she coughs, laughs, sneezes. Any physical activity that leads to SUI, you need to first squeeze before you do it. So first woman will consciously squeeze. So it's called performing the knack. So she consciously contracts before any increase of abdominal pressure. And when she keeps on practicing that conscious contraction before coughing, laughing, sneezing, or jumping in the gym, etc., over time it becomes a behavioral modification. So that is how pelvic floor muscle strengthening helps you. Regular strength training and bracing or performing the knack. Now, the number of Kegel exercises to do per day, right? So Kegel is basically an involuntary inward and upward contraction or squeeze of the pelvic floor, right? A very important thing to understand is that you have to isolate the pelvic floor from the abdominal muscle. So she should be trained to squeeze the pelvic floor without squeezing the abdominal muscles. Now, the exact number of Kegel exercises to do per day is very, varied. I mean, the evidence says that you can do it from 8 to 12, 3 times a day to as many 200 contractions per day. And you might contract for 4 seconds, or you can do 30 to 40 seconds, right? And how long do you do it? Commonly 3 months, right? This is what is generally told about therapy with Kegel. Now, the problem with Kegel is that unfortunately 50% of women cannot identify their muscles, and 27% of women will do reverse Kegel. So never tell a woman to do Kegel exercise at home unless you've actually assessed the Oxford score. Put 2 fingers in the vagina and ask her to squeeze around it. You will find 50% of women cannot identify their muscle. Now, when I tell her to go and do those Kegel exercises at home, it's like, patients come to me and say, oh, I've been exercising for 2 months, 3 years or so. And I assess them, and their muscles are very weak because they don't even identify and exercise the right muscles. Worse is if they do reverse Kegel, meaning when you're asking them to squeeze, they're actually pushing. That will worsen their SUI. I have had patients coming like that who've been told Kegel and they're actually doing reverse Kegel and they have worsened the SUI. So in my practice, biofeedback is extremely important to understand that these are the newer therapies that come in. And in my practice, biofeedback has become an extremely essential tool as a first-line treatment for patients with SUI and also overactive bladder. Now, what is biofeedback, right? Now, if you go to the gym and you lift a dumbbell, you'll be able to see your hand lifting a dumbbell. But when I ask the patient to exercise a pelvic floor, I won't be able to see how she's doing it, nor does the patient understand whether she's doing it correctly. She's thinking that she's doing it correctly, but she can't actually see it. So what is biofeedback? Biofeedback is her physiological process of contraction is transformed into a visual, acoustic, or a sensual information that she can see on the computer. And when she can see how well she's contracting, you're able to train her to exercise better, identify the right muscle, and exercise them over time. Correct? So how do I do that? Now there are, and how does biofeedback help you? What it does is that it alters the pathophysiological responses of both the smooth and striated muscle that mediate bladder control, right? And it helps in recruiting more pelvic floor muscles to improve contractile force, and it reinforces bladder inhibition, right? Now the thing is this, is that once you strengthen the muscle biofeedback, over time you have got regular endurance increased, and you can perform the knack or the bracing technique as I told you earlier. Now, women come for biofeedback once a week for 12 to 15 sittings. We start off with biofeedback, and in the same sitting, we will do electrical stimulation after that. Electrical stimulation is like a passive man's Kegel. Okay, so I'm going to cover this. Now, how do I do biofeedback? Now, I'm going to talk about the biofeedback system I have, but biofeedback basically, different systems have different ways of doing it. But basically, it's an electrode, right? This will be an anal probe. So I have a maple electrode. This is the highest end electrode. Basically, what it is it's a probe. And this probe goes in the vagina or the anal canal. And if you see, there are 24 electrodes on it, these golden dots, right? Now, these 24 electrodes, when the woman squeezes, they will transmit information to the computer screen. You can also use a anal manometry probe. So this is an electrical stimulation probe, whereas I can also use a pressure transducer probe, right? Like an anal manometry soft probe. So you can use different kinds of probes, right? Depending on the machine you use. I'm going to tell you about the maple so that you understand broadly about the principles of biofeedback and electrical stimulation are. So you put a probe in the vagina and you ask the patient to squeeze around it, right? So because there are 24 electrodes, what happens is I get an entire grid. You see this? And all the muscles of the vagina, of the pelvic floor, I can see as a grid. This is anterior muscles, posterior muscles, lateral muscles. So what happens is I can assess at rest and during contraction the pelvic floor muscle strength with reference to a reference group. This is a reference group, right? And then I'm comparing the muscle of the patient with a reference group. If the color is white, you see some of the rings are white. So this muscle is white. That means the strength of that muscle is equivalent to the reference group pelvic floor muscle strength. And the reference group would be number of normal women in the same age group, right? And if it's red, it means the muscle is hypercontracted. So in this patient, her urethral sphincter is hypercontracted. This is anterior urethral sphincter. And even the anal sphincter is hypercontracted. And if you look at lateral muscle, this is blue here, right, on the right. So the right, the left of the patient, the left lateral levator muscles are weak because they are blue, correct? So blue is weak, red is hypercontracted, and white meaning it's equivalent to the reference group. So what do I do? When the patient comes to me weekly, I will assess her pelvic muscle at rest. Then I will see her. And why am I assessing at rest? It's very important that when we exercise, you're also able to relax the muscles in between exercise. If it's a hyper-contracted muscle at rest, it's not going to help you. Because sometimes, if there's an imbalance of contraction of pelvic floor muscle even at rest, that can cause leaking. Okay. Now, next is I'm going to do 3 quick, large, quick contraction and big contraction. Maximum voluntary contraction. Okay, and I'm assessing the strength of the type 2 fiber. I told you the type 2 fibers are the quick contraction fiber and quick relaxation fiber. So I'm going to ask her to do quick contraction, quick relaxation 3 times. And I'm going to see how she's doing it. And even she's going to see it. Then I'm going to do 10 times to 20 times long contractions. So you see this 10-second hold, 10-second relax, 10-second hold, 10-second relax. And I'm going to see how well she's contracting and how long she's holding the contraction. Very important. Sometimes a woman may have very good Oxford score, 4 or 5, but she's not able to hold a contraction. So you can't just tell her, okay, go home and do Kegel exercise, 10-second hold, 10-second relax, because it's like flogging a dead horse. over time to build up a muscle strength. So when I see the computer screen and she sees the computer screen, I'm able to help her understand how to contract so that she's able to kind of recruit the right muscles. Then in the first time when she comes, I'm going to see how long she could hold a contraction, how many times she could hold a contraction, okay? How many seconds she could hold, how many times she could hold. Then I'm going to give her homework. What is her homework? Her homework is, okay, suppose a woman could hold 4 second long, 4 second relax 4 times. Her homework will be, I will ask her to hold 2 seconds more than she could hold, 2 times more than she could hold. So she'll get up in the morning, go to the bathroom, come back, sit on the chair, and then I will exercise the type 1 fiber, the long contraction fiber. So 6 second hold, 6 second relax, 6 times. Why? 2 seconds more than she could hold and 2 times more than she could hold, right? So 6 second hold, 6 second relax, 6 times. I'll give her a half an hour break to rest the muscles, and I will ask her to exercise the type 2 fibers. That is 2 second hold, 2 second relax, 6 times. Right? So both the muscle fibers I'll exercise depending on how well she could do it in front of me. And she would do it 3 times a day. Again, afternoon, the same thing she will do with a half an hour break in between. And the night, again, she'll do the same thing with half an hour break in between. Now, this is how I will improve her muscles over time. Next time when she comes back, I'll be able to see whether she can hold better and how she's doing it, right? So with time, her muscle strength improves and she's doing under supervision. Also, very important when she's doing the exercises, also, we will all abdominal EMG leads. So that we are ensuring that she's not contracting abdominal muscles while she's contracting pelvic floor. Very important train like that. No contraction abdominal muscles while contracting the pelvic floor. Now, when I do this exercise at home, 10 second hold, 10 second relax like 10 times, I will get an average, right? So look at this. I'm getting a whole muscle grid. A muscle grid at rest, right? I'm getting a muscle grid at maximum voluntary contraction. Look at this. This patient has very poor muscles, right? In comparison to reference group. Blue, right? At maximum voluntary contract, type 2 fibers. Look at the type 1 fibers. Only the right lateral, inner levator muscle are strong enough. But when I'm asking her to do most of the contraction, long contraction, other muscles are blue. Meaning I can look at the average EMG and the peak EMG. You see this? With over time, I can follow her up, right? After the biofeedback, I'm getting the average EMG, peak EMG. I'm able to see how the EMG, peak and average are increasing. And with time, she should be able to make all of this red. And she will know how she's improved over time. It's also great motivation for the woman when they come back weekly. Okay, and look at this woman, right? This woman could not hold a contraction. You see this? When she first came in, this is endurance contraction. She could hardly identify. I trained her. Look at the next week. Next week, she could hold, but her amplitude was not good. Right? Over time, her amplitude also will become better and the amount of variability will reduce. That is how you improve over time. And in the same sitting, when they come weekly, I also do electrical stimulation. Electrical stimulation helps in motor excitement and also acts as an analgesic, right? Pain, it's a wonderful pain neuromodulator. But electrical stimulation acts like a passive Kegel exercise. And that can be done through either vaginal or anal electrode, the same probe, right? So a probe in the vagina, it's like a lazy person's Kegel, the thing that is doing Kegel for you. And the good thing about Maple is I actually decide which muscles to stimulate. So if you see this particular patient, at maximum contraction, her, look at her right lateral, more lateral most levator muscle, very blue. I can decide I only want to stimulate those because I want to strengthen them. So I can actually choose which muscles to stimulate. And then I can use different frequencies. If a woman has stress incontinence, I would use 50 or 100. If a woman has urgency incontinence, I would use 10 or 12, 12.5. And if it's mixed incontinence, I would use 20 hertz. I won't go into patients who have got dysfunctional voiding. That's a very different kind of biofeedback, and we use 200. One thing I will tell you about the electrical stimulation for incontinence, it is intermittent stimulation. It on off of 50 hertz for stress incontinence, right? So it's around 20-minute therapy. And Cochrane clearly says that pelvic floor muscle strengthening is the first line therapy. In my practice with biofeedback, 70% of patients do not require surgery at all. And it really works very well, right? Now, when will I do surgical therapy, right? So I've got 15 minutes more, I'll cover surgical therapy, do and don'ts, right? When should you do what kind of sling surgery, right? Or what kind of surgery helps? If you got surgical treatment, when you do it, when your failed conservative treatment, like biofeedback does not help you, and severe incontinence that can happen, right? Women who have got ISD, intrinsic sphincter deficiency, the most severe form of SUI, right? And these are women who are leaking very early. These are women who are leaking only even after voiding. Right? Like you ask them to empty the bladder, they only have the post-void residual inside the bladder, and when you ask them to cough, these are patients with intrinsic sphincter deficiency, right? Severe incontinence. These are patients who might end up with surgery, right? So now let's go through each surgery, their pros and cons, right? I won't have time to go through surgical steps. Maybe another time I can take a bigger lecture, because SUI by itself is a huge topic, right? Now, the first surgery is, of course, Bursch Colpo suspension. Now, the take-home message: never, ever, ever do Bursch in patients with intrinsic sphincter deficiency. Remember that. Intrinsic sphincter deficiency is diagnosed based on urodynamics. In urodynamics, I would do maximum urethral closure pressure. It's called MUCP. If the MUCP is less than 20 centimeter water, or the Valsalva leak point pressure, I don't need you. Please don't remember this. Just know that these are the pressure. These are measurements and help us understand urethral strength, right? The sphincter strength, right? The maximum urethral closure pressure and the Valsalva leak point pressure. When they are low, the patient has intrinsic sphincter deficiency. Never do Bursch in a patient with intrinsic sphincter deficiency. So before doing Bursch, remember one very important thing. In my patients, if the conservative treatment biofeedback fails, I will do urodynamics. On urodynamics, I will understand the sphincter strength. If the sphincter is weak, I will never do Bursch. Okay. Now, Bursch, that is another thing. The success rate is around 60 to 90% 1 year and 70% 10-year cure rate. Problem is that in Bursch, you are pulling the bladder neck anteriorly, so then they can have an increased risk of having enterocele. Now, around 5 to 27% can have de novo urgency incontinence develop. And systematic reviews have clearly shown that the Bursch is actually inferior to retropubic slings, both subjective and objective cure rates, right? So that is the thing about Bursch. Now, retropubic bladder neck sling or pubovaginal sling, right? So when you have, now, these are coming back into the vogue, right? Now there are, rectus fascia slings, or there is fascia lata sling. These are autologous fascia. And the autologous fascia you put at the bladder neck. It's not at the midurethral level, at the bladder neck. They are also called as pubovaginal slings, or they call as retropubic bladder neck sling. Why? Because you put it like TVT. They're retropubic. They go not like transabdominal, but like retropubic slings, and they are placed at the bladder neck. And you would do this in ISD patients, right? ISD patient again is MUCP, that's maximum urethral closure pressure less than 20 centimeter water, or the Valsalva leak point pressure less than 60 centimeter of water, right? So I would do it in ISD patients. I would also do it in patients with previous failed incontinence procedure. And the long-term cure rate is 85 to 90%. And it has been clearly shown that pubovaginal sling are as effective as midurethral sling for ISD. However, because you put the pubovaginal sling at the bladder neck, they can have more storage symptoms or more obstruction symptoms. See, what happens is this. In patients with ISD, patients in whom you have got sphincter deficiency, you want to obstruct the urethra a little bit at the bladder neck. That is very different from how midurethral slings work. Midurethral slings are put at the midurethra and they work by dynamic compression. Whereas you are putting the pubovaginal sling at the bladder neck and tighter. You know why? Because you wanted to cause a little bit of obstruction, because the sphincter is weak, so you want to support it more. Now, but it can cause more voiding dysfunction. It can also cause more storage symptoms. Okay. Now, now in the market, you also have something called as iStop, and the iStop is it's not a fascial sling. It is basically a mesh which can be put at the bladder neck, right? So it's similar to a pubovaginal sling, but it's a mesh. Now, let's come to the, midurethral slings. The midurethral slings are either retropubic slings or the transobturator slings. Okay. Now, both the retropubic sling and transobturator sling, how do they work? They work at the midurethra by causing dynamic compression, right? Now, the theory behind this is that you have weak pubovaginal ligaments, right? You have the pubourethral ligaments, sorry. The pubourethral ligaments are weak in patients with SUI. So when you have weak pubourethral ligaments, what happens is your midurethra is not well supported. When your midurethra is not well supported, you will leak because there's no support when you cough. So you replace the pubourethral ligaments, weakened ones, with a sling, a mesh, which supports urethra at the bladder, midurethra. You see the support here, right? So you can put it either retropubic. See, this is a retropubic sling. It's going around the urethra and coming out above the pubic symphysis. Or you can use a transobturator sling. Now, what is the evidence? Because I do not have time, I'm going to go to limited evidence, right? So basically, remember one thing very clearly. According to European guidelines, At the 5-year rate, you see the first line, right? At 5 years, the outcome of both the transobturator and the retropubic is the same. But at 8 years, retropubic sling is more, effective. It has higher objective patient-reported cure rate. Remember that. More durable is transvaginal tape. Transvaginal tape is TVT tape is retropubic. TVT retropubic tape is more durable at 10 years than the transobturator sling. At the 5-year point, both are similar, right? Very important. Next, and you see the other yellow? Now, transoperative sling are of two types. You can put it outside in or inside out. Okay? The different makes of transoperative sling in the market, outside in or inside out. Both are similar in terms of efficacy, up to 9 years. Remember that. Okay? Very important. Now, they've also said very clearly that when you do birch, right? Let's listen to this. When you do birch, what happens? In birch, your urethra, the bladder neck is pulled into the abdomen, right? In birch. Now it can keep the bladder neck open. Because it can keep the bladder neck open, you should never do that ISD patients. Intrinsic sphincter deficiency patient cannot undergo birch for that reason, because birch tends to make the bladder neck an abdominal organ. The urethra, the proximal part of the urethra goes into the abdomen. And so when the patient coughs, the bladder neck is kept open, and that's why she will leak more. That is why you must not do birch in a patient with ISD. So this is the evidence according to European guidelines, right? The most important evidence, right? Now, in my own practice, I find transvaginal tape retropubic the best. Why? Because it has got the highest, longest evidence backing it. Remember that you're putting on a mesh in a patient, and if you do not put a mesh that's got evidence backed by evidence, there are a lot of side effects that can happen. There are a lot of adverse effects that can happen. Now, TVT 11-year evidence very clearly, right? This is a paper out of Finland, and where clearly they showed that at the 11-year point in 90 women, they found that subjective cure rate was around 9. Objective cure rate, that is cough stress test, right? What they do is patient comes full bladder, and they ask the patient to cough, and they see the leak. It's called cough stress test, and success rate was 95% at the 11-year point, right? That means in 95% of patients, when they made the patient cough on full bladder with 300 ml inside, she did not leak, right? So TVT has very good evidence backing it, right? And the same patient, they followed up over 17 years, and even then 90% were objectively continent. Very important, right? Now, the point is that you will come back to me and say that so many papers say TVT is equivalent to TOT. Now, what is the problem here, right? Remember one thing, most papers which say TVT is equal to TOT, they are not looking at mixed incontinence patients, and they're not looking at ISD patients. Remember this. All papers on SUI generally do not look at ISD patients, intrinsic sphincter deficiency, or mixed incontinence patients. We haven't found the right cure for ISD patients. In patients who are not ISD, who are just pure SUI without the severest form of it, TVT is equal to TOT. However, in ISD patients, TVT is better. So remember one very important thing, that even in TVT papers, most of them are not studied ISD patients. So be careful before assuming TOT is equal to TVT. Yeah, so this is the papers, right? So if you look at TVT versus TOT in ISD, out of 55 RCTs, only 8 reported for ISD. And in ISD patients, the short-term and medium-term subjective cure rate is better for TVT, right? And very important thing you must remember is that if you undergo TOT, your chance of undergoing repeat incontinence surgery in the long term, more than 5 years, is higher for TOT. Remember that. This is very important to remember that TVT is equal to TOT at the 5-year rate, but TVT is better at the 8-year point in all patients of SUI. But overall, in ISD patients, TVT is better even in the medium term and the short term. Okay, TVT better for ISD patients than TOT. In normal SUI patients without ISD, TVT is equal to TOT at the 5-year point, but the 8-year point, TVT is more durable. Remember that. So in the garden variety SUI, without ISD, both approaches are similar outcomes. Remember that. Okay, but now the complications of retropubic sling, right? So why do people talk about retropubic slings being difficult, right? That's because they say, okay, you have to do cystoscopy. Cystoscopy has to be done even in TOT patients. Remember that. I only need 5 minutes more, okay? So you have to do cystoscopy even in TOT patients. Remember that. It's not true that in transoperative slings you don't need to do cystoscopy. Second very important point is this. There's a lot of complication reported with retropubic sling. That is bladder perforation. But remember that the newer types of TVT sling have needle introducers, which are very thin and made of a material that doesn't damage the bladder. Right? So you can even perforate twice. And yet you can put it again. Okay. So because retropubic slings are blind, the perforation of bladder is a possibility, right? So even if you do it twice in one sitting, it's fine, right? Now, and also because TVT is tighter, because lying mid-laterally, it's supposed to cause most voiding dysfunction, right? There's more chances of patients having dysfunctional voiding after you put in a sling. But is that really the case? It's not. If you look at voiding dysfunction, if you look at patients who underwent surgery for voiding dysfunction after sling surgery, the number of patients who underwent surgery for voiding dysfunction after sling surgery is more for transoperative sling than TVT sling. Remember that. Overall, you may have more patients coming to you after sling surgery with TVT saying that I have difficulty to pee, but most of them recover. And more patients with TOT will undergo surgery for voiding dysfunction after sling surgery. Remember that. That's the evidence. Second very important thing is, when I put in a transoperative sling, I'm going through parts of the body I have no idea about. When you put in the transoperative sling, go from operator foramen to operator foramen, right here. This part, areata longus, medius, all of these areas, no medical field actually operates in that area. Neither us, nor the orthopedicians, nor the surgeons. I have been part of 3 surgeries where we tried to remove a transoperative sling, and it's very, very, very difficult. Okay, so remember that. Whereas, when you do a retropubic sling, you're going through the space of Retzius. And the space of Retzius, all of us understand, right? So it's easier to remove TVT sling than a TOT sling. So do you do TOT in all SUI patients? No, you have to individualize. If a patient has ISD, put in a TVT. Younger patient, put in a TVT. Okay, older patient with voiding dysfunction, I might put in a TOT. Now, again, an editorial in the IUJ clearly saying that's more durable. How about the new mini slings? The mini slings are transoperative slings, but they are smaller. Like, see, the thing about transoperative sling is there is a very big chance of groin pain, right? The earlier transoperative slings had mesh going through one operative membrane to the other operative membrane. When the mesh goes to the muscles, it can cause pull and cause pain. So there are newer transoperative slings which are mini slings which go in through the vagina, right? But they don't come out through the in a manner in which that they will cause groin pain. Why? Because the amount of mesh is small. In a TVT abbrevo, you have threads at the end, protein threads at the end, and they don't go through the muscle, right? The mesh doesn't go through the muscle, and that's why the pain is less. So evidence says that there is comparable outcomes of TVT O, that is a transoperative sling, and TVT abbrevo, which is a mini sling. So mini slings have similar outcomes to transoperative sling, but they have reduced post-operative pain. Okay, remember that. Now, how does a mini sling compare with TVT? Now, TVT meaning the retropubic sling, they are similar only in pure SUI patients. I told you this. In pure SUI patient, doesn't matter what you put in. You can even put TVT abbrevo, you can put in regular transoperative sling, or you can put in TVT. They have got similar objective and subjective cure rates. However, never put in a TVT abbrevo in an ISD patient. Okay? Laser therapy. No. It's coming to the market, it's market driven, but the evidence is clear that it is not, as of now, there is no evidence backing it. In my practice, most mild, moderate SUI patients do not require anything more than biofeedback. Laser, what I talk about, helps only in mild SUI, but mild SUI patients do so well in only physiotherapy. Why would I do laser? And I have had patients coming to me during my training in the US, where laser just come in. Patient would come back with stenosis, okay, because of indiscriminate use of laser. So please understand, laser, right now, evidence for laser only for atrophy, not for SUI. And evidence might come out saying that SUI, it is useful in SUI. But in mild, physiotherapy is very good. And moderate physiotherapy is very good. You don't need to do laser, right? So this is what evidence clearly says, right? And US FDA has clearly issued a warning against laser therapy, right? So you need more robust clinical trials required. Mixed incontinence, remember this, that in mixed incontinence, again, younger woman with mixed incontinence, I would put in a TVT. Why? Because reoperation rates are much higher in the transoperative tape group. Okay, relative risk is more than 10.1%. Recurrent SUI, again, I would put in a TVT. Remember that, not a transoperative listening. Lastly, SUI with prolapse. I'm going to end with this slide. Don't look at this slide, just listen to me. If a woman comes with SUI and prolapse, remember, very, very important thing is that always look, if your woman comes to you, she has got prolapse and she also has leaking of urine, obvious leaking of urine, then you can offer therapy, that is sling surgery along with prolapse surgery. Okay. However, if a woman comes with prolapse and she has no leaking, absolutely no leaking, you have to look out for occult incontinence. Why do you look out for occult incontinence? What happens is prolapse kinks the urethra. When prolapse kinks the urethra, the leaking is not obvious. And you will do prolapse surgery, and the patient will come back to you after surgery saying, I'm leaking. Right? I never leaked before, but I'm leaking after surgery. It's not that the leaking was not there before, it was masked, it was hidden. Why? Because prolapse kinks the urethra. So, what is very important that when a woman of prolapse comes to you, always look for occult incontinence before surgery. How do you do that? You push the prolapse back and you put your finger beneath the uretrovesical junction and straighten the urethra and ask the patient to cough and see if she leaks. If she leaks, if it's a very obvious leak, you might offer a sling surgery along with prolapse surgery. However, it's not a very obvious leak. There is a leak, but it's like after a lot of coughing and the woman doesn't look very, amenable for it. You might tell her, look, I saw leaking at the time of coughing when I did, when I looked for it, but we might treat it later on. Okay, maybe the prolapse surgery itself will take care of it. Okay. However, if you come back with leaking afterwards, I'll take care of it at that point. You tell a woman this because if she comes with leaking later on, she will tell you didn't tell me about it. Okay, next thing. Last group of patients is you reduce the prolapse, you ask the patient to cough, okay, and she doesn't leak in front of you. No matter how much you try, you're not able to elicit leak. Even then, 32% of patients might still leak after surgery. Remember that. Why? Because no matter how well I check, because there is prolapse, it's sometimes very difficult to reposit the prolapse back very well. And when you ask the patient to cough, the prolapse again comes out and kinks the urethra. So no matter how well you check for occult incontinence, sometimes you're not able to assess properly. So 32% of patients who did not show you leaking before surgery, even though you examined her well, will still show leaking after surgery. So you prognosticate and tell her that I didn't see leaking in front of me, so I'm not going to treat it. But you may still get leaking after surgery. If it happens, I'll take care of it at that particular point in time. Thank you. Lastly, bulking agent. I'm not going to cover it. It's not yet come to India. Bulkamid is coming to India. What is bulking agent? Bulking agent is an agent. It's a silicone agent or a collagen agent that you inject through the cystoscope at the level of the bladder neck. I've done macroplastic in the United States. I've done a few bulkamids as a kind of a demonstration in India, but it only has 60% success rate. You might use bulking agent in patients with ISD. They've got an open bladder neck. So one might just do an injection at the bladder neck to kind of close it. The success rate is only 60%. Okay, thank you.
Thank you, Dr. Akparna. So, is the question and answer session allowed now, Dr. Madhuri?
We can take one or two questions. We have a question in the chat box. Dr. Samir Pradhan has asked, we observe sometimes patients are lost to follow-up when we advise urodynamics. So how do you counsel the patient for prolonged biofeedback? What if we do the TVT which would address both genuine SUI and ISD and simultaneously advise biofeedback to prevent recurrence? UK has banned TVT mesh too and gone back to lap Bursch. Soon what they do for ISD?
Yeah, I'm going to come to this one by one, right?
Yes, ma'am.
I see, I have a proper urogynecology setup. My patients never go away only because of the fact that my first visit 1.5 hours. We have an 8-page questionnaire that goes to them. There's a lot of counseling that happens. They really understand every step. They feel very supported. If you have only 5 minutes, 10 minutes with the patient, they will go away, right? Basically. So you need to really work with them to ensure that they understand how you're going to do it, counsel properly, and my patient then really come back to me. And when you send for urodynamics, if you really counsel the patient properly and you have an association with the person you're sending for urodynamics, then patient will feel supported and come back to you. Next is my patients really biofeedback works beautifully for me. 70% of my patients do not require even urodynamics or sling surgery. They work very well. Pure SUI, ISD patients, biofeedback will not be enough. But genuine SUI leaking once in 2-3 days works beautifully. And I would want to do the patient what I would want to be done to myself. And I wouldn't want to undergo surgery when biofeedback will work so beautifully, right? No, I would not agree that you should not do TVT to address both genuine SUI and ISD and then advise biofeedback. No, biofeedback therapy should always be the first line therapy. Cochrane review clearly says that, and that's what we follow in our practice. If it fails, only then, because you might go and do surgery in a patient in whom biofeedback would have been enough, and you wouldn't want to do that. Second very important thing, many patients have reverse Kegel. I told you, 27% of patients have reverse Kegel. Okay, and in that patient, if I go and put in a sling, it will fail. Okay, because they're pushing. Their regular thing is to push. Third very important point, I'm happy to cover this particular point. Most of patients are leaking also have prolapse along with it. Correct? Okay, now, hopefully next time I'll show you an ultrasound of how it works. Right? I can show you dynamic ultrasound of it. When you have prolapse patient, long-standing prolapse and leaking, they have a tendency to push to pee. Correct? Because they have got a prolapse, the urethra is kinking, they will push to pee. Now the problem is they will have dysfunctional voiding, that means, right? Now, if in a patient with prolapse, I have not trained her to void better. Okay, I do physiotherapy to train a patient with, I do urodynamics where I can clearly see how are they voiding. Okay, if in a Valsalva voider, right? Valsalva voider is a woman who voids by Valsalving. If I do prolapse surgery without training her how to void better, at the same time I put in a sling, it will obstruct. What does the sling know? Sling only knows to tighten when a patient is pushing. But if she is used to pushing to pee, the sling will obstruct to doing peeing. You getting my point? So, such very important, a prolapse patient, you have to train her properly to contract better, not to pee by pushing, and all of that you achieve by biofeedback, and then only put in a sling. I have patients in whom prolapse patient with SUI surgery has been prolapse SUI surgery done at the same time, and they come back with voiding dysfunction. Not because the sling was tight, but because patient only knew how to push to pee and the sling obstructed. Okay. Lastly, in UK, UK TVT is coming back. In the United Kingdom, going forward, TOT is banned. TOT is banned. Transoperative sling is banned. TVT is back. Okay, TVT will be back. So they will put TVT for ISD and they will do bladder neck sling. I told you, no, rectus fascia and fascia lata. They will do rectus fascia and fascia lata for the bladder neck. Now, I'll tell you this very importantly, right? It is, and hopefully some other day I can show you my ultrasound images of how the slings are inside a patient. When you put in a sling, how does a sling work when a woman is laughing, coughing, sneezing? It's very easy to put in a sling. It's very difficult to take it out. And once you put it, it obstructs and changes the anatomy completely. So be very careful about that. Also, another thing I'll tell you, please use the right quality mesh. Very important. You need to use macroporous polypropylene meshes. Macroporous means big pore size. A lot of the Indian-made meshes have small pore size. When you have small pore size, what happens? See, when you put in a mesh, how does it work? It fibroses in place by fibroblasts going into the holes, right? The pores. If you have small holes, bacteria will go through the pore, but the fibroblasts and macrophages can't go through the pore. And then they will have infection and they will have encapsulation, and she's your friend for life. You've infected a patient in the horriblest area. So please understand, you may not have any side effect or adverse effect while using a microporous Indian-made mesh, but be careful. Also, a lot of the Indian-made mesh are very thick. Do not use a thick mesh. There's enough evidence out there saying that the pore size and thickness is very important. Okay, I've answered the question. Yeah.
Ma'am, one query from my side. Ma'am, where is this facilities available, biofeedback, and what is the cost?
And Kama has it. So that is, in Kama, I'm building a whole department of urogynecology. Right? It'll have the highest end urodynamics. It'll have the highest end biofeedback. Even the poor will get biofeedback before they go in for surgery. So Kama, there's a whole department of urogynecology being built, right? As an honorary, I'm building it there, right? So government, it's Kama, and private, of course, I do it. And Delhi also we do it. But it's important to do the right thing by the patient. So of course, hopefully, when people come to train, they'll train in it and go out and do it.
Thanks a lot, ma'am, for the excellent.
I think we will take up more question and answer session at the specified time of 4:15 p.m.
Okay.
But it was an excellent talk, Aparna, and there will be a lot of questions, I believe, and questions still are coming in. And we will encourage questions till the end of the session on any topic whatsoever. Even the faculty, even the delegates can put in the questions. So, Aparna, please stay back. We will like to see that some questions are directed towards you once again at the back of the session. Now, because of the lack of time, I would like to request the chairpersons to proceed for the next session, please.
Yes. Thanks a lot, ma'am, for the excellent talk. And thanks a lot, Dr. Lowell, for chairing the session. We move on to the next session. Can we have the CV of the next chairperson? Our next session is a talk on wall prolapse by Dr. Sameer Pradhan. The chairpersons for this sessions are Dr. Sandhya Saharan. Madam is the first vice president of the Thane Obstetrics Gynec Society. She's a consultant OBGYN practicing in Jupiter Hospital, LH Hiranandani Hospital, Kaushalya Hospital, and Curia IVF and Birthing Hospital, Thane. Madam has received the Young Scientist Award in 1994 and also the recipient of the H. Disa Silver Jubilee Award in 2001. She's received the Best Paper in International Congress in Infertility in 2003. And she's devised the nomogram for labor monitoring. Welcome, madam. Our next chairperson is my dynamic friend, Dr. Madhuri Mahendra. She is an assistant professor in the Department of OBGY at Lokmanya Tilak Medical College and is the managing committee member of MOGS since the last 8 years. Can you, madam, can you please read out the CV of our speaker?
Yes. I am very happy to introduce Dr. Sameer Pradhan, who is not only a close friend of mine, and we've been associated for the past so many years. Dr. Sameer Pradhan is an MD from the State GS Medical College and Wadia Maternity Hospital. He's done his DGO, FCPS, DFP from the College of Physicians and Surgeons, Mumbai. He's the director of Samarth Maternity and Nursing Home, Mulund East, consultant at Godrej Memorial Hospital and Shushusta Hospital, Vikhroli East. He's also a visiting consultant at Fortis, Jupiter, and Curie hospitals with a special interest in gynec endoscopy, vaginal surgeries, and high-risk obstetrics. Welcome, Dr. Sameer Pradhan.
Yeah, thank you so much, Sandhya, for such an excellent introduction. And at the outset, let me thank the Obstetric and Gynec Teachers Forum for giving me this opportunity. And without wasting too much time, I have to few videos and let me try to stick to time. Let us start with the wall prolapse. Can you see and hear me properly, Dr. Sandhya?
Yes, sir.
Yes, sir.
Yeah, perfect. All perfect.
Mean by wall prolapse is post-hysterectomy prolapse. The International Continence Society describes it as a descent of the apex of vagina, that is the vaginal vault, or the cuff scar after hysterectomy below a point that is 2 centimeters less than the total vaginal length above the plane of the hymen. And this point, according to POPQ, corresponds to the point C. And in as many as 72% of the patients, they can have associated cystocele, rectocele, or enterocele. Why is wall prolapse important? It has a tremendous negative impact on the woman's quality of life because it can be associated with urinary, anorectal, and coital dysfunctions. And it will be so distressing for the patient who feels that after a hysterectomy, all gynec problems are over. So once if they have a wall prolapse, they have to come back to a gynecologist. It is very distressing to the. The types of wall prolapse are the apical wall prolapse is the true vault eversion. The scar of the vault is the first thing which comes out. There can be sometimes a false wall prolapse, which could be an anterior compartment defect like a cystocele. Cystoceles can be central, which we commonly know, but there can be a undiagnosed lateral or rotatory cystocele, which is a paravaginal defect, which might not have got corrected in the first surgery, and then it recurs from that side because there is a defective area. There can be a posterior compartment defect like an enterocele, which can be a traction enterocele where there is a cystocele and a rectocele which come out and then they pull the enterocele away with it. Or there can be a pulsion enterocele where it was missed in the primary surgery, and then since that is a defective weak point, once the patient, the hysterectomy is done, that enterocele starts increasing in size. There can be only a pure rectocele or a combination of all the above with lax perineum. Now, the traditional classification of wall prolapse is first degree, where the apex is just visible when the perineum is depressed. Second degree, the apex extends just through the introitus. Third degree is upper 2/3 of the vagina is outside the introitus. And the fourth degree, the entire vagina is outside the introitus. Nowadays, for research purposes, or if anybody has to present a paper, one should also know the POPQ classification. One, obviously, everybody knows about the Delancey's support. So the level 1 support is the apical support. So what the take-home message from this slide is the apex offers a significant support to the anterior wall. And apical support is most important, else the best anterior and posterior repair during a primary surgery can fail. This was very nicely described by Schul et al. In the American Journal of Obstetrics and Gynecology. So the important thing is to, whenever one is doing a hysterectomy, one has to do a apical support. So what are the precautions one does during a vaginal hysterectomy? High ligation of P pouch, posterior pouch is important. That is, that way one reduces an enterocoel. If an enterocoel is present, one has to repair it. I will show in my video subsequently. Here one has to plicate the denonucleus fascia at the apex. One has to tie both the uterosacral pedicles at the center, and one should not tie the cornuals at the center because that can cause dyspareunia. So this tying the uterosacral pedicles at the center gives the effect of a shortening similar to the Schirotka's uterosacral advancement surgery which was there with an intact uterus. Anchoring the pedicles, uterosacral pedicles to the vault has level B evidence according to the RCOG. McCall's scaldoplasty, I have started performing in all cases of where I do a hysterectomy for prolapse. It is level B evidence. And according to level C evidence, mentioned that sacrospinous scalpofixation prophylactically at the time of hysterectomy should be considered when at the end of the surgery, the vault descends to the introitus. Certain precautions have also to be taken during an abdominal hysterectomy, and this can be extrapolated to a laparoscopic hysterectomy or a robotic assisted hysterectomy, wherein one always suspends the vault with the uterosacral stumps. This is similar to a McCall's. Alternatively, the vault can be cut above the level of attachment of uterosacral, so the attachment of uterosacral remains intact to the cervical cuff. High uterosacral ligament suspension can be done additionally if one finds the uterosacrals too lax, but one has to take releasing incisions, which I'll show subsequently. Recently, people have started plicating the uterosacrals as we used to plicate the round ligaments to retrovert, to antivert the uterus. But it has to be done with a non-adsorbable suture like a proline polyester, that is Ethibond. So Ethibond has better knotting properties for laparoscopic surgery. If there is a very deep pouch of Douglas, one can do a Moshkovitz or a Halban's repair. And a subtotal hysterectomy is not recommended for prevention of post-hysterectomy wall prolapse, level A evidence according to RCOG. So this is the McCall's scaldoplasty. The first stitch which goes to the vault has to be with an absorbable suture. Second and third stitch can be non-absorbable for a better support for a long time. And the ureters, the intermediate part of the uterosacral ligament is very near the ureters. And even if the ureter is not included, sometimes the ureter kinks and then it causes obstruction and hydronephrosis. So one can take these religion incisions which are shown. These are the photos of Hemi Moshkovitz. One prefers Hemi Moshkovitz. Otherwise, one can obstruct the rectum while doing the Moshkovitz. And this is a Halban's repair. I have never done Halban's. How does one evaluate a case of vault prolapse? Obviously, one have to ask history of the primary surgery and the route of hysterectomy. Because nowadays, sometimes when a lot of people are using cautery, even in vaginal surgeries, but even after that cautery use, the vault has to be suspended by a stitch to the uterosacrals and the vault. So this may not be done if one is doing a vaginal hysterectomy with cautery. One has to ask history of chronic straining factors like chronic cough, constipation, or difficulty in micturition, and that has to be addressed. All my patients nowadays, when they do a sonography, I have started doing a post-void residue, and because most of these patients have a this urethral stenosis, and that can be addressed in the primary surgery so that the micturition part is also addressed. And the desire for coital function helps to decide which surgery choice has to be done. While examining, one should examine the previous scar, the extent of damage, and whether there is any coexisting incontinence. So here, one for enterocoel, one has to see whether that enterocoel is the leading part or not the leading part. One can also palpate the enterocoel and know whether there is any bowel loop there. For cystocoel, one should see where the rugosity ends. That is the place where the pubo-vesico-cervical fascia has got detached and is lying there. So one has to reconstruct that fascia. And these lateral sulcuses which are shown are very important. If there is a absence of lateral sulcus, it means there is a paravaginal defect on that side which has to be addressed, if possible vaginally if one has the expertise, or then a laparoscopy or help may be taken. But sometimes doctor, and I asked this question to Dr. Ajay Rane, he said a good apical support more or less takes care of these lateral paravaginal defects according to his experience. While assessing the rectocele, one also sees the rugosity and also assesses the vaginal length and mobility to confirm whether this patient is suitable for a sacrospinous fixation. Conservative management, unlike for SUI, which Dr. Aparna madam very nicely demonstrated, for a wall prolapse, it has very limited role only for stage 1 or 2 wall prolapse. There is a role of supervised pelvic floor muscle training. Ring pessaries can be used on a temporary basis till the patient is fit for surgery, because this patient sometimes can be old and moribund, because they have 10% risk of discomfort and mucosal excoriation. So just making a list of all the surgeries one can approach vaginally or abdominally. By abdominally, one can also replace abdominal root by laparoscopy or robotic assisted. They are the sacral colpopexy and pectopexy. While the vaginal suspension can be a suspension operation, or if the patient has no desire of sexual function, one can use obliterative procedure. Let us see all this. McCall's scaldoplasty, I don't use as a surgical treatment for wall prolapse. I use it more often as a preventive, as I had mentioned earlier. So going to the first surgery which I would like to describe is a sacrospinous colpofixation. Here one is doing suture fixation of the vaginal wall to the medial portion of the sacrospinous ligament, which is the lower cord-like structure within the body of the ischiococcygous muscle. And it was introduced as early as 1971 by Nichols and Randall. Earlier, they used to use delayed absorbable. Nowadays, I use non-absorbable number 1,0-proline. But my mentor, Dr. Rajendra Sarvage sir, who has taught us all this through his live AFG workshops, prefers to use Vicryl. The recurrence rate, the largest prospective trial was by Hefney and Tukhi, which showed that after a proper sacrospinous fixation, the wall prolapse recurrence was only 5% and anterior recurrence is 15%. So we always do a anterior colporaphy before doing this sacrospinous colpofixation. So to address this problem, there are a lot of complications if not done properly. That could be intraoperative or postoperative hemorrhage, injury to sciatic nerve or internal pudendal vessel. Rectal wall is very near, so rectal wall injury risk is theoretically there. Most of the patients, if the nerve is involved, they get buttock pain, which on its own subsides after 2 to 3 weeks. And if the excess vagina is cut, the patient may have dyspareunia later on. So let us see the video. Sorry.
Here we are describing right sacrospinous. Initially, the A repair has been done, and we are straight away going to the steps of the sacrospinous colpofixation. This surgery was chosen because of the cardiac risk to the patient. We have not used adrenaline, we are just infiltrated normal saline, and the
doing dissection done. Like a P repair.
The vagina is been dissected right up to the wall. The two allies forceps are holding the vagina, rectovaginal fascia. We are slowly going right up to the wall. This is very important step because we have to also do a repair for the apical central defect. So here we are showing the plication of the denonucleus fascia at the apex. We are taking a 2-0 Vicryl on a round body needle, and we are transfixing and plicating the fascia at the apex. So this step helps in preventing enterocele in future. We need not open the posterior peritoneal pouch, only the fascia can be plicated. So once this thing is done, the same tissue is taken through the apex, and the dead space between the vagina and the fascia is been obliterated, and the fascia is been separated from the vaginal edge.
Now we are doing the dissection.
So with this, it reduces the amount of blood loss. Gospis is giving counter traction on the rectum, and the rectum is being pushed medially. So facial fibers are dissected by the help of the cautery, and subsequently we will do a blunt dissection. The index finger has to roll over and push the rectum medially, and we are creating a space in the right pararectal space so as to reach the sacrospinous ligament on the right side. One important step in this point is we are cutting the lateral rectal fibers. This helps in creating an additional space, and the rectum gets pushed medially. And then one has to put 3 retractors. One is the same speculum, which is going to push the rectum medially. One is our angle and Landon's and the Devers retractor. And we can here see the sacrospinous ligament, which is the thickened part of the ischiococcygous muscle. We use suction to just make the ligament more prominent. It is seen like a fan-shaped structure. And then we have to be 2 fingers away from the ischial spine so as to avoid injury to the internal pudendal artery and the sciatic nerve. A special way to hold a needle is like as if you're holding a straight needle. You have to go from below upwards, and you have to take 2-0 proline, and a double helical suture is been passed to the sacrospinous ligament under vision. Once the 2 sutures have been taken, one has to do a test wherein one pulls the ligament and sees literally the patient moving. This ligament, the suture is taken subepithelially through the apex of the vault. So, because it is a proline suture and it cannot be exposed in the vaginal mucosa. So, a proper fixation is done at the vaginal vault, and subsequently the P-repair steps have been completed. Here we have taken a levate and a stitch so as to reconstruct taken. We have to tighten the sacrospinous stitch which we had taken earlier. The important step in this is since it's a proline suture material, the knotting has to be like what has been described in the textbooks for proline. The first has to be a double throw, and like a pulley action, the vault you can see the vault going right up to the right sacrospinous ligament. Subsequently, one has to take at least 5 throws so that it becomes 2 + 1. Procedure, we have seen a nice depth of the vagina, and this has gone up, and we can also do a 2-finger test.
So the salient points in this is the perforation of the rectal pillar on the right side. I have done almost 30 such cases in the last 20 years, but I could do the dissection on the left side only one. But I could not take a stitch because of the curve of the rectum comes there. So I have not been able to do on the bilaterally. I do only on the right side. One has to safeguard the pararectal veins, especially in the obese patients. And I have earlier used to use a 1 number proline, but the needle was too big and difficult to maneuver. There are other ways. There is a capio device which is available abroad. Some people perforate with mixture. Our teacher from KEM, Dr. Shashank Pururkar sir, and his student, Dr. Manoj Chavan, they used to use mixture. And there's a suture pass, which is a needle which orthopedics use for arthroscopy. Dr. Manik Guram uses that suture pass. So these are all different techniques people have devised to overcome the cost of the KPO device. Then the other surgery which is there, which is a close competitor of this surgery, is a high uterosacral ligament suspension. It provides apical support, that is a De-Lance's level 1 support, which we had mentioned earlier. Described in 1927 by Miller and popularized by Schul in the 1990s. One has to identify the remnants of uterosacral ligament by dissecting near the dimples laterally. And an interperoneal approach is better where the bowels are packed with long devers at 12 o'clock and angle Landons at 9 and 3 o'clock. A transperitoneal palpation of ischial spine is used as a guide to guide and find the remnants of the uterosacral ligament. The upward traction on the Ellis forceps at 4 o'clock and 7 o'clock helps to identify the intermediary part of the uterosacral ligament during the vaginal approach. And one has to do a high uterosacral ligament fixation. So a 2-0 or 1-0 vicryl suture is taken. The first suspension suture is placed just above and medial to the ischial spine on the tissue lying over the groove next to the bowel with a visual check on the course of ureter. Those who have done shoutouts or assisted shoutouts can tell how a ureter can be identified vaginally. I have yet to identify it vaginally. This is that's why I taken this talk from Dr. Raja Maheshwari's talk, lecture. Second and third can be delayed absorbable or non-absorbable sutures. They are placed one above the other. The first suture traction helps to put the above suture. They are taken from lateral to medial side. Else, if you go from medial to lateral side, one can damage the ureter because ureter is very close near the intermediary part of the uterosacral ligament. The procedure is done for both the sides, and the midline approximation of pubocervical fascia is done with 2-0 Vicryl as we do in a traditional A repair. And the first limb of the suture is passed through the pubocervical fascia and antevaginal wall, and the posterior limb is passed through the rectovaginal fascia and the posterior vaginal wall. And the second and third sutures, which can be delayed absorbable or non-absorbable, are passed only through the fascia. So here is the photo of all the way how it is, the vault is suspended at the apex. The redundant vaginal wall is trimmed and the antevaginal wall is closed halfway before tying the suspension sutures. And ante and posterior limbs of all three pairs of sutures are tied together on both sides, thereby elevating the wall to the pubo-cervical and the rectovaginal fascia and anchoring it to the uterosacral ligament. I am going to this next weekend to learn a V-notes, which is a new thing which is coming. It's called a vaginal natural orifice transterminal endoscopic surgery. I just took 2 photos from this Dr. Suyash Naval's talk, where in this we can see the ureter much better. So it will be more helpful while doing a high uterosacral ligament suspension. That is my personal opinion. There was an optimal trial by Barber et al., which was the largest prospective trial compared to sacrospinous and the high uterosacral ligament suspension, where patients were closely followed for almost 2 years, and 85% of the patients had follow-up. So the results were that both were safe with less than 5% of serious adverse events. Ureteral obstruction was seen in 3.7%. That was 5 patients. And it was diagnosed intraoperatively in 5 patients and postoperatively in 1 patient. But these were all cases of high uterosacral ligament suspension. And buttock pain was seen in 4.3%, and in 4.3% it persisted for beyond 6 weeks. These all were sacrospinous ligament fixation. It also reiterates the fact that only behavioral therapy and pelvic floor training did not improve the prolapse outcome for 2 years. So after high uterosacral ligament suspension, cystoscopy is must to rule out ureteral kinking. Coming to the obliterative surgeries, it corrects the prolapse by closing of all the portions of the vaginal canal. That is called colpoclysis, and thereby deposits the viscera back into the pelvis. Of course, indicated when the patient is not fit for surgery or not sexually active. One has to rule out endometrial and cervical cancers, any uterine pathology like fibroids or any adnexal pathology. These surgeries cannot be done in patients who have any of these pathologies. The complication is a post-op SUI, hence the incision should be away from the bladder neck and the mid-urethra, as we can see. And these patients have a tendency of recurrent UTIs, and sometimes the hematoma can be found if there is no proper hemostasis. So coming to the
steps surgery of Lafort's by Dr. Samir Pradhan. Lafort's is a vaginal surgery done for post-hysterectomy wall prolapse. Saline adrenaline is infiltrated and anterior and posterior vaginal rectangular flaps are removed. Here we have seen the anterior flap being removed, and here similarly a posterior rectangular flap is removed. Subsequently, we start suturing the pubo-cervicovascular fascia to the rectovaginal fascia, and the wall prolapse get reduced. As we take more and more box stitches, the wall prolapse is reduced. We put a rubber catheter to drain the secretions. Here, after the surgery, the last bit is remaining, and the anterior and the posterior vaginal walls are approximated to each other, and we achieve a partial to complete colpoclysis. Sometimes we have to do a posterior colpoperineography. Here we have seen the posterior colpoperineography being done, and the final skin sutures being taken, and this is the final picture where a complete colpoclysis has been done. One can always put a pack for 24 hours, and this surgery helps the patient to be ambulatory from the next day.
So Lefort described this surgery in 1877, and in that rectal flaps are removed. So Goodell Power modified this surgery where he removed triangular flaps with the base of the anterior of the triangle at the anterior and posterior fornix. So the end result, there is a single vaginal canal in the lower 2/3, so patient can have intercourse, and there's a double vaginal canal in the upper 1/3. My PG guide and the famous Dr. Praveen Matre used to always prefer Goodell Power's modification as an obliterative procedure over Lefort. The Dani stitch is an intraoral tightening where the prolapse is deposited and the introitus is tightened with a non-absorbable ethylone suture. I have never done Dani stitch in a gynec patient, but my teacher, Dr. Nandanwar, if there is a patient of pregnancy with prolapse and has a urinary retention, we used to reduce that prolapse and put a Dani stitch, but with Vicryl. And then that retention used to get rectified, and at term we just have to give episiotomy. So that was a paper which was presented in one of the MOGS conferences. So that is Dani stitch. Now coming to the abdominal and laparoscopic or robotic surgeries for prolapse, the two main surgeries. Here one has to use a polypropylene mesh, the macroporous monofilament, which Dr. Aparna was stressing. And for suture fixation, one can use a ethi bond. It has better knotting properties than Prolene. Or one can use PDS, which is delayed absorbable suture. I have done only a laparoscopic hysteropexy, but that's why I'll be using somebody else's data for this. The sacral colpopexy is the strongest and most durable correction for prolapse. There was a meta-analysis of almost 30 trials by Gion, NJ et al. And they said it is the procedure of choice, especially in young active patients, patients who have connective tissue weaknesses and history of multiple hernias, patients who have a chronic intra-abdominal pressure raised conditions like asthma, chronic bronchitis, or chronic constipation. If a previous pelvic organ prolapse repair has failed, or there is an insufficient vaginal length for a transvaginal repair. There was a CAD trial. The CAD trial was mainly a colposcopy and urinary reduction efforts trial, mainly done to assess the number of SUIs which occur after this colpopexy surgeries. But the incidental finding of the trial was that anatomical success is almost up to 76 to 100%, and only 4% required reoperation. There are certain drawbacks, however. Defecation disorders and constipation can occur in as many as 17 to 37% cases. There can be de novo SUI in up to 20% of the cases. Backache is a problem. There can be intraoperatively presacral bleeding or rectal injury. If tackers are used during laparoscopic procedure, one can get osteomyelitis of sacral promontory, and the removal of that is very, very tedious. The mesh can erode if the vaginal this wall is very thin, and the mesh erosion patients are very difficult to manage. Some patients have an infective lumbar lordosis, and if the hypogastric nerve is not safeguarded, one can have voiding difficulties. I am going to use certain pictures from a presentation of Dr. Revas Botchor-Shivilai of Clermont-Ferrand. He had presented this in a webinar of the IAG, and I have taken his permission for this. The first step is to have a good exposure, so the rectosigmoid can be suspended by a T-lift device or by taking just the suture through the appendix epiploicae with ethylone. The sacral promontory has to be exposed properly, and that is the place. The dissection should be enough to allow 1 or 2 sutures properly on the anterior longitudinal ligament near the sacral promontory. And the green areas in the last photo is the best place to place the mesh. One has to safeguard the common iliac, right common iliac artery and the left common iliac vein. And in a laparoscopic surgery with the pneumoperitoneum, the left common iliac vein sometimes can be compressed. So one has to be very careful while doing this dissection, because the venous bleeding is very difficult to manage. Medially, there is a medial sacral artery which comes from the aortic bifurcation, and that also has to be safeguarded. Also, one cannot go very low down because there could be the emissary vessels from the sacral foramen, which also is difficult if they start bleeding. Then one does a pararectal dissection. So one has to be medial to the ureter in the middle pararectal space, or the Okabayashi space, and one has to trace the ureter right up to the where it goes near the vault. Then for the vault dissection, the posterior vaginal vault is dissected from the rectum right up to the levator ani, and the anterior vaginal vault is dissected from the bladder. My Y-shaped mesh is used. And the posterior mesh fixation, the mesh is fixed. One has to cut the mesh in the center to allow the rectum to go, and fix to both the mesh is fixed to both the levator ani muscles posteriorly. And then along the posterior vaginal vault, anteriorly it can be fixed quite low up to the bladder base, so it can take care of the cystocele also. Then both the mesh are united at the apex of the vault, and then it is fixed to the sacral promontory. I have a video of pectopexy where we can understand it better. After this mesh is fixed and the assistant sees from below that it is apparently tightened, the mesh is fixed and the peritoneum has to be always sutured, and this is the final view after the surgery. The pectopexy was devised by Professor Nui Gunter of Germany, and I was lucky to meet him personally during a STAR conference in Pune 2 years back. His fixation points are the iliopectoral ligaments of Cooper, which we used to always use for burst repair. The advantages are it is less invasive. There is a bilateral fixation of mesh. It works as a hammock parallel to the levator ani muscle. The apex remains as S2 level, which is a normal vaginal axis. The axis of vagina is maintained. It is well away from the rectum, ureter, and the hypogastric nerves, so there is less chance of injury to the major vessels and the nerves. And the suturing laparoscopically is easier anteriorly, as one will agree, it is easier to remove an anterior myoma than a posterior myoma, especially for those who do ipsilateral suturing. Here, these are just steps where the mesh is fixed to the vault, then fixed to the right iliopectoral ligament of Cooper and the left iliopectoral ligament of Cooper, and then the peritoneation has to be done. If time, do we have time for that 3-minute video? Hello?
Yes, sir, please go ahead.
Yeah, so this is a courtesy Dr. Ameya Padmawar. It is showing a laparoscopic paravaginal repair with pectopexy. He gave me a 7-minute video, which I tried to cut short to 3 minutes. Let us see. So this is a vault. Here one is going to dissect the anterior and posterior. The vault, the fascia has to be dissected. And it has to be left on the bladder anteriorly and the rectum posteriorly. So the vault is exposed. Here we are seeing the right side iliopectoral ligament. This is being exposed anterior to the round ligament exit because it's going to do a paracervical, paravaginal defect repair also. And the left pectoral ligament is exposed. This is the bladder. The subsequent is in the dissection is in the cave of Retzius. One can see this video completely on YouTube. It will be much easier to understand. I am just showing the salient points for sure, want of time. So you can see the whole iliopectoral ligament being exposed and the bladder in there. And then the tissue near the bladder will be fixed to the iliopectoral ligament. This is the paravaginal defect, which is that also causes lateral cystocele, wherein the arcus tendinous fascia pelvis, the pubocervical fascia get detached from the arcus tendinous fascia pelvis, and we have to reconstruct that particular fascia. Same thing is on the patient's right-hand side. One has to be very advanced with suturing skills because one has to take a lot of sutures. This is different from Bursch. Bursch, the sutures are placed near the mid-urethra and they cannot be tightened. They have to be kept loose. Here, the sutures have to be tightened. Then the peritoneum is closed where the cave of Retzius was open. And now the mesh has been placed. For only pectopexy, one has to dissect posterior to the round ligament exit. The important structure here is the corona mortis, which has to be safeguarded. It is a vein. It's a superficial circumflex vein which connects the obturator in vein to the extrailiac vein. So if that vein bleeds, there can be bleeding from both the extrailiac as well as the interiliac vessels. So it can be torrential. That's why the curve of the needle should be away from that vein. Vein is lying more laterally. So here the pectoral ligament has been taken first and then the mesh has been fixed. and subsequently they will do the peritonization of the mesh. All the mesh which is kept in the abdominal cavity has to be peritonized, otherwise it can cause very bad sigmoid bowel and sigmoid colon adhesions, and the patient can have a very miserable life. They can have intestinal obstruction, mesh infection, a lot of other problems. This is a final picture. It's a very advanced surgery, a laparoscopic paravaginal repair with pectopexy. Thank you, Dr. Ameya, for this video. Now coming to almost the second last slide, this is the take-home message for all. I have taken it from the RCOG Green Top Guidelines of 2015. Women should be aware that the abdominal sacral colpopexy or laparoscopic are equal, and sacrospinal fixation are both effective treatments for a post-hysterectomy wall prolapse, evidence A. But the abdominal sacral colpopexy is associated with significantly less recurrence, less dyspareunia, and less SUI compared to sacrospinous fixation. But this did not reflect in significantly low reoperation rates or higher patient satisfaction for either of the two surgeries. Obviously, sacrospinous colpofixation being a vaginal repair has an early recovery, but it cannot be done in patients with short vagina because the vagina has to go up to the sacrospinous ligament. And if the patient has a pre-existing dyspareunia, it will get worsened after a sacrospinous colpofixation. The laparoscopic repair is as effective as the abdominal sacral colpopexy. There was a new paper by Freeman et al. Which demonstrated the de novo SUI in only 15% of cases of laparoscopic sacral colpopexy compared to 45% in abdominal sacral colpopexy group. I do not understand why the difference. There is limited evidence for robotic sacral colpopexy. There is a level evidence C, but Parasio, who was a previous president of the AAGL, and she had come to India, I had met her last year. She reported she does robotic sacral colpopexy, and she reported similar results, but robotic surgery was more expensive and operating time was longer. The high uterosacral ligament suspension is to be offered as a first line only in context of research, evidence B, and has a risk of ureteric injury. And Lin et al. Has reported recurrence rate of 10% with no ureteric injuries following lap uterosacral ligament colposuspension. Obviously, lap is much easier. The whole ligament is seen in front of you, and one can take the incisions to lateralize the ureters. Colpopexy is a safe and effective procedure in frail women and or women who do not wish to retain sexual function. I thank you everybody for a patient hearing, and for the undergraduate and postgraduate students who are there. I would like to acknowledge this and guide them that these are the reference books. I refer to my teacher, Dr. Vivek Patkar sir, who had come to my hospital and showed me Lafort's and sacrospinous holding my hand. He has a very good PPT presentation on wall prolapse and also describes the whole anatomy in detail. This book, the left-hand book, was released during the AICOG Mumbai 2013. All the prolapse surgeries and all the other surgeries like Fothergill's and everything are described in detail. Dr. Rajendra Sarogi sir is one of the main editors. And in recent AICOG, this other book on your vaginal surgeries, from wherein the POPQ can be found over here in great details, and also one can find a high uterosacral ligament suspension by Dr. Raja Maheshwari. I thank you everybody for the patient hearing, and I thank.
I'm on, huh? Now, no, it's not 5 minutes.
I had done last slide. This was last slide. Thank you everybody.
Thank you, sir. On behalf of both the chairpersons, I would like to thank you for such a detailed talk and so much oriented, both having a practical touch as well as a theoretical touch of specific importance for all our students. So we now move on to our next session. The students are desperately waiting for this important case presentation. This case will be presented by Dr. Rashi Korea, who is a JR3 student of LTMMC Science. And we are fortunate to have very senior, passionate teachers over here as the examiners for this case. Our first examiner is Dr. Niranjan Maidev, sir. He's a head of department in KEM of Department of Obstetric and Gynec at KEM Hospital and GS Medical College. He's interested in a lot of research and is the principal investigator of ICMR. His special interest is high-risk pregnancy, and we all know him as the most student-friendly teacher. Our second examiner is Dr. Rajendra Sarogi, sir. He hardly needs any introduction. He's known as teacher of teachers. He's an ex-honorary professor at St. G.S. Medical College and KEM Hospital. He's ex-honorary and head of department at R.N. Cooper Hospital. He's a senior consultant at Nanavati Hospital and also a director of his own group of hospitals. He's past president of Malad Medical Association. He's a past president, managing trustee, and a founder member of Association of Fellow Gynecologists. He's several chapters and books to his name. He has got a very long CV, but everybody here knows him very well. Our next examiner is Dr. R.V. Maikar, sir. He's an associate professor and head of department at our very own institute, Lokmanya Tilak Municipal Medical College. He's one very, very passionate teacher and a very student loving and loved by all to have him as a teacher. And our last examiner is Dr. Amarjeet Bawa. He's an additional associate professor in the unit at our department at Lokmanya Municipal Medical College. A special interest is in emergency obstetrics and gynec endoscopy. Welcome. Rashi, can we have you share your...
Yes, ma'am. Ma'am, am I audible?
Yes, you are. Are you sharing your screen, Rashi?
Yes, ma'am.
Yeah. Slide. Slideshow.
XYZ 26.
Rashi, can you please put on the slideshow?
Yes, ma'am.
Hi, Niranjan.
Hello. Good afternoon, sir.
Nice to see you.
Really. Same here, sir. Same here.
Hi, Sameer.
Hi, sir.
I listened to your lecture. It's too exhaustive.
How was it, sir?
It was good, but too exhaustive. You require about 2 hours.
Oh, thank you.
Hello, Rashi, are you there?
So glad my teachers, Dr. Niranjan.
Yes,
kindly click on slideshow which you have.
Someone request.
Can you see the slide?
Yes. Please go ahead
Nice
now.
to see Dr. Saraugi. Nice to hear his voice. Dr. Saraugi, how are you, sir?
I'm good.
Okay.
Looking in your OT dress, fantastic. Yes, Dr. Rashi, please start your presentation.
Everyone, I'm Dr. Rashi Koviya, third year resident at Sion Hospital, hereby presenting a case on nulli gravida prolapse. Yes.
Hello. We can't hear you.
No, she's not audible.
She's not audible.
There is a network issue from her side, sir.
Hello.
Rashi, unmute herself.
Rashi, unmute yourself.
आशीष तुम्हारा टॉक नहीं सुनने को मिलता है हमको.
Hello.
Yes, Rashi.
Hello, ma'am. Am I
Somebody has to help her.
Yeah,
You're audible now.
Tech support, please help her. Please help Rashi to unmute herself.
From her side, network issue is there, sir. That's why I have stopped her video. So
Okay.
Sir, I have unmuted myself.
Okay. I can see only Rashi's beautiful photograph, but I can't hear her voice.
Can the tech support play the slide and then she can present? So there's a network issue, only audio will run better.
I'll do that.
So Rashi, will you please stop sharing your screen? Hello, Rashi.
Rashi is having an internet slow speed, and therefore the audio is not going to help.
Yeah.
So I have shared for her.
Yes.
Yeah.
She requires a stronger net connection.
Yes. Is Rashi speaking now? We can't hear her still.
Hello, Ruja.
Okay, I think Madhuri, we can go ahead with the second presentation now, if that solves the issue.
Sir, actually, both the students are together. They'll be presenting from the same device.
Okay.
So, Dipali, the last option is ask them to give you a call and keep it on your and let them present.
I'll do that, sir.
I'll do that. Actually, they are reconnecting, and if it doesn't work, we will do that.
Am I audible now?
Yeah, you.
Yes.
Yes.
So is the slide? Is the slide visible?
Yeah, he's projecting it.
Rashi, just start.
See,
will have to speak into your phone.
I have shared your screen for you. So you have to say next. So I'll change the slide. Please go ahead.
Okay. My patient, Mrs. XYZ, 26-year-old, resident of Dharavi, educated till 5th standard, laborer by occupation since 7 years, low socio-economic status, married since 3 years, nulli gravida, came to our OPD with chief complaints of something coming out per vagina since 2 years. The mass has increased in size over the 2 years. It increases on straining and lifting heavy weights. It is reducible on lying down and by digital deposition. Next slide, please. No complaints of pain in abdomen, no complaints of foul smelling discharge, no complaints of menstrual irregularities, no complaints of urinary incontinence, no complaints of painful or burning micturition, no complaints of straining while passing urine, no complaints of constipation, no complaints of postcoital bleeding. Next slide, please. Her menstrual history, she attained menarche at the age of 14 years. She has regular cycles since then of 28 to 30 days with normal menstrual blood loss, which is not associated with dysmenorrhea and passage of clots. She is nulli gravida. Next slide, please. Her past history and family history is not significant. She is vegetarian by diet and no history of any addiction. And she consumes 1800 kilocalories per day, which is less for her. Next slide. On general examination, her height is 150 centimeters.
Hello.
Weight is 40. Hello.
Rashi, can I intervene in between?
Yes, ma'am. Sure.
Can I ask you a question over here?
Yes, ma'am.
On the history, can you tell us what is your differential diagnosis?
Ma'am, just on the history.
Just the history.
Sir, ma'am, just on the history, I can say that if the patient is complaining of a mass per vaginum, it can be a polyp, it can be a cyst, it can be a prolapse, and it can be urethral caruncle.
Urethral diverticulum. Urethral diverticulum. Okay. What else?
And
congenital elongation of the cervix.
Yes, ma'am. Congenital elongation. Cervix.
Okay.
Yes,
okay. Carry on.
There was mild pallor present, no icterus, cyanosis, lymph node enlargement. Thyroid examination was normal. Her pulse is 84 per minute, BP 110/70. Respiratory rate is 18 per minute. Cardiovascular system and respiratory system are normal. Next slide, please. On per abdomen, Abdomen is soft. There is no guarding rigidity and tenderness, no ascites or organomegaly, no hernial site seen. On local examination, patient was placed in dorsal position without straining. Vulva, labia, and perineum was noted normal. There was no gaping present at the introitus. Cervix was seen at the introitus. Next slide. On per speculum, a patient was asked to cough. There was grade 2 uterine prolapse with uterocervical length of 3 inches. Cervical length was 1 inch. No evidence of cystocele or rectocele. Cervix and vagina healthy. No evidence of any growth. No discharge or ulcer seen. No bleeding on touch. And no evidence of SUI. Next slide. On PV, uterus was retroverted, normal size, bilateral fornices were free and non-tender. The final diagnosis which I made was 26-year-old nulli gravida with grade 2 uterine prolapse with no cystorectocele. Next slide.
Can I ask you over here?
Yes, ma'am.
Grade 2 uterine prolapse, according to which classification you have to mention?
This was grade 2 uterine prolapse according to Shaw's classification. And next slide, please. Ma'am, according to the POPQ classification, this is stage 2 uterine prolapse.
Okay. Hello?
Hello. Yes, ma'am.
Yeah. Okay. How are you going to manage this patient?
For this patient, as this patient is young and is nulli gravida and she would like to conceive in future, I would like to do a Shirodkar sling surgery for her.
Shirodkar sling surgery. Have you ever done it before?
No, ma'am.
So how will you do it? See, you have to. Yeah.
Can I intervene in between?
Yes, sir. Yes, sir.
Yeah. Few things you have left out in your examination. You just read no hernial sites. What does it becomes very difficult to understand. Either she has hernia or she has no hernia. There cannot be any no hernial sites. We have definite hernial sites. So when you mention, you have to be very clear about it.
Okay, sir.
Whether she has any hernias and what hernias you have looked into. That is one aspect. Second, you have not mentioned about the abdominal tone of this particular lady. Third, you have not made a mention about, the anal reflexes, the tone of the levator ani. Nothing has been mentioned. This should be a part of your examination when you are going to complete your examination before you go into final diagnosis.
Rashi, I would like to ask you, are you appearing for MBBS or you are appearing for MD?
Sir, for MD.
For MD. If you are going to waste your time only in no this, no that, no this, no that, what will happen? The time is limited. You want examiner to go on ascites? You want examiner to go on BMI? Do you want examiner to go on obesity? Or you want examiner to ask you about prolapse? So you should skip all those things. Those which are not relevant, you should not bother about it.
Okay, sir.
You should always try and drag the examiner towards your topic of choice rather than examiner dragging you to the topic of his or her choice. You'll get caught and instead of prolapse, something else will be asked to you. Remember one thing, examiner is bored listening to prolapse. If he gets a chance on BMI or somewhere else, he is sitting on the other side of the table. He can ask any question without knowing the answer. Keep that thing in mind.
Yes, sir.
That was one. Second thing, what is the reason behind second degree prolapse in her case? Generally, we expect a delivered patient or multiparous, normal delivery getting prolapse. Why she got prolapse at such a young age? What could be the reason?
Sir, she can...
How do you differentiate between infravaginal elongation, that means congenitally elongated cervix, as Dr. Bava said, or it's a genuine prolapse? How will you differentiate? Tell me the things.
Sir, in this case, the cause of prolapse can be a connective tissue disorder, or it can also be due to malnutrition. The patient is low socioeconomic status.
50% of India's population is malnourished or anemic. Do all of them get prolapses?
No, sir. So because malnutrition can be an additional factor to this.
So it's a connective tissue disorder. Do you want to say connective tissue particularly for the ligaments only?
No, sir.
Then?
If you would have any connective disorder, there would be associated symptoms.
So did you try and find out? Do you think she can get second degree prolapse only without cystocele, without rectocele? If she has got second degree prolapse, there has to be something associated with it, no? If it's only ligament or connective tissue disorder, you want to say pubo-cervico-vagico-vaginal fascia was spared. Do you get in nulliparous prolapse all those problems? I say it's an infravaginal elongation of cervix, congenitally elongated cervix. How do you differentiate between two? The symptoms remain same. Patient complains of something coming out per vagina. And on examination, you will find second degree prolapse. It's an undergraduate question. It's not even a postgraduate question. How do you...
Where will be the external loss, Rashi?
Ma'am, it will be down. It will be seen at the introitus.
In congenital elongation of the cervix, you won't be able to deposit the external loss above the level of the ischial spine.
Ischial spine.
Okay, that is the differentiation between in a multiparous and in a nulligravida.
That's one part of it to look at it, but there are different ways to really identify between infravaginal and the, what are the other ways?
How will you know?
Yeah, how will you know that it is congenital elongation of the cervix or it's a prolapse?
UCL is 3 inches in both. Just examination, how do you know that this is not infravaginal elongation? It is 100% supravaginal elongation. It's a simple question and simple answer.
Can you measure the infravaginal part of the cervix?
We will measure the... Sir, we can measure the infravaginal part of the cervix. We can measure the total cervical length.
Once the prolapse has occurred, it's going to be difficult. How do you know? You put in a speculum. What happens to the speculum if it's a prolapse, and what happens to the speculum if it is infravaginal elongation? You make her cough, you make her strain. What happens to the speculum if it's a prolapse?
Is there a strain on the speculum?
Sir, when we yes, sir. When the patient coughs, there is strain on the speculum, and the prolapse will size will increase, or the descent, it will descend.
My dear girl, in infravaginal elongation of the cervix, the fornices are deep. In cases of prolapse, the fornices are shallow. So you put in a speculum, make her cough, the speculum will fall down if you don't support it. While in infravaginal elongation, it will stay aram se udar.
And the cervix will be seen comfortably at your level, wherever you want. Okay.
Now come to the management. How will you manage? You said chirurgical sling, I'll do. So you will call Dr. Amarjit Kaur for that.
What other surgeries are available? If you don't know how to do chirurgical sling, what are the other surgeries which can be done, Dr. Rashi?
Purandare sling surgery is an easier option for this patient.
Let's come to that now.
Cervicopexy.
Why it is called as pexy? What is PEXY and what is PAXY? It is cervicopexy, PEXY, no?
PEXY, sir.
What is PEXY and what is PAXY? What is the difference? Where do you use the word PAXY? I'll give you full marks if you can answer that. Have you heard of litholapexy?
No, sir.
No? Crushing the stone is PAXY. And PXY is fixing something. So it is cervicopexy, PEXY. Clear?
Yes, sir.
Okay, so you said Purandare cervicopexy. Further?
Then there is...
Why not chirurgical suprasectal advancement?
Yes, sir.
Which is a vaginal surgery. Patient
Vaginal
is happy, you are happy. Why do you want to?
What is the objective of sling surgery in your case? Hello.
Hello. Am I
Yeah.
audible?
Yeah.
Ma'am,
Yeah.
if after doing sling surgery, the patient can deliver vaginally without any problems. She is a young patient, and it is fertility preserving for her as she is nulli gravida. And in Shirodkar's sling surgery, the anatomical position of the uterus is maintained.
Okay.
Rashi, my main question was why not do uterosacral advancement rather than opening up the abdomen? Why can't you do uterosacral advancement in her case? Rahul Gappa hai kai re baba?
In other words, what sir is asking is that, what are the points that go in favor of a Shirodkar sling? What are the points that will go in favor of a uterosacral advancement? What are the points that will go in favor of a Purandare's cervicopexy?
Advantages and disadvantages, I suppose.
How do you select the surgery? That is what sir is asking.
Primarily, how do you select a surgery, whether it's an abdominal route or the vaginal route?
When there is associated cystocele or rectocele, we usually choose a vaginal route. We can repair the cystocele and rectocele at the same time, along with the prolapse.
Very important thing is also you have to know what the tone of the uterosacral is, which you missed out when you spoke about your examination.
But if the
especially in
if the uterosacral are weak, we cannot do the uterosacral advancement.
That's it.
If the uterosacrals are weak, we cannot do the uterosacral advancement of
So in a nulli parous lady, what do you think about the uterosacral and the transverse cervical ligaments? What do you find? Are they weak? They are strong?
What would be in a normal case? Whether they would be weak or they will be strong?
They would be strong.
Women.
They would be strong. Sir.
If they would be strong, would have
strong. Why will she have prolapse?
If the ligaments would have been so strong, would the prolapse have occurred or no?
No, sir.
So then you are answering both ways.
So the ligaments are weak, no?
There can still be a prolapse. Dr. Rashi, if the ligaments are strong, they can still be a prolapse, and it is called as vagino-uterine prolapse. And then you get a different type of condition where you get something called as a supravaginal elongation of cervix along with prolapse. Uterine prolapse.
Tell me the difference between both Purandare cervicopexy and Shirodkar sling.
Sir, Purandare's cervicopexy is a dynamic and anterior sling. Shirodkar's sling surgery is a
Why it is called as dynamic?
Sir, it is attached. So because it is attached to the rectus sheath, and it is called static when it is attached to a strong bony support. As in the Shirodkar sling surgery, it is attached to the anterior ligament of the sacrum.
Do you fix it to the sacrum or do you fix it to L5? You never go up to the sacrum, you go to the L5 anterior longitudinal ligament.
It's difficult to fix at the level of the sacrum. L5 is very easy for you to see at that particular juncture. What is the dynamism in Purandare's pexy? You say it's a dynamic sting. What are the advantages, if at all there are any?
Sir, it is easier to perform and
easier to perform is dynamic. A dynamic is a person who does the things which is not easily done by others.
In short, on clinical examination, can you distinguish whether it is a Purandare's pexi or a Shirodkar sling.
Yes, probably what Rahul says gives you a hint, what exactly really happens.
And a beautiful hint, in fact.
Beautiful hint, yeah.
Sir, on clinical examination, the uterus is anteverted in a Purandare's sling surgery.
That you have to do for any surgeries, round ligament plication. What Rahul asked you is, can you really make out what type of sling it was on examination?
I'll put it simply, patient has come to OPD, you are the boss, and patient says some operation has been done from above. I had a prolapse and some operation has been done from above. So how do you know that it is Purandare cervicopexy or Shirodkar sling? Immediately that these two things will come in your mind, correct?
Yes, sir.
So how will you know whether it is Purandare cervicopexy or Shirodkar sling? You can see a nice scar on the abdomen. और यू विल टेल योर रेसिडेंट्स दोनों में से कोई एक तो होगा मालूम नहीं अभी जाने दो.
What happens to the uterus when she really coughs or in a Purandare's pexy or she tightens her abdominal muscles?
You said no. The pexi is attached to the rectus sheath.
Yes, sir.
So what will happen when there's cough?
So it will. As the rectus muscle contracts, the uterus will move with the antevert with the coughing reflex.
Oh no, it doesn't antevert.
It will move.
All the pelvic organs move with cough.
Will it move downward or will it move upward with the cough?
It will move upward with the cough.
Ah.
Anything else? Which are the advantages for a Purandare sling? One, it will move up, so the chances that recurrence occurs is slightly less as long as the tone of the abdominal muscles is good. Any other advantages? What do you have to do along with Purandares to reduce the recurrence of prolapse subsequently? Is Purandares done alone or we do something?
Do we do some plication?
Round ligament plication is.
That's one. Something which Dr. Pradhan just mentioned.
Why?
Do you do something for the pouch of Douglas?
You will have to obliterate, na?
We obliterate the pouch of Douglas, ma'am, because in the Purandare cervicopexy, as the uterus is retroverted, it deepens the pouch of Douglas. So we need to obliterate that in order to prevent enterocele formation.
Okay. Going back to the sling, what are the advantages of Shirodkar sling?
Sir, it is anatomically the most correct sling surgery, and it provides a strong bony static support to the uterus. And here, as the uterus is anteverted, the pouch of Douglas is not deepened also, and it prevents enterocele formation, unlike in Purandare surgery. And if a Purandare surgery has been performed, and the tape might get cut during if an LSTS is performed later. Shirodkars overcome this disadvantage.
Okay. Yeah, you're right.
How do you make a
Do you?
choice in your patient? What will you do? We have different options. I mean, you can't leave that option to the patient at the particular moment. तुमको ये चाहिए क्या वो चाहिए नहीं है. You have to make a decision. कि, okay, this is better for you. How would you make a choice?
Sir, as this female is young, she has no elongation of the cervix also, and that's why I would like to do a sling surgery for her. And
What all will you counsel her when you're planning a Shirodka sling? What are the prerequisites for doing a Shirodka sling or any conservative operation? Is it possible that you can plan a Shirodka sling and you might have to abandon it once you open the abdomen?
yes, sir, if there is there is a vascularity over the sacrum and difficulty to get to the anterior longitudinal ligament, or we will look for the sigmoid colon if
Usually sacral promontory is very avascular, except for the median sacral vein which you can tackle. That's not a problem. And especially since you're doing the sling in the post-menstrual period. So prerequisites, you have to be the conservative surgeries have to be necessarily done in the post-menstrual period. You have to have a normal pap smear. Anything else? So the vascularity on the sacral promontory is usually not an issue. Very rarely. What is more common? What is there in the floor of the pelvis at the pelvic brim or just below the pelvic brim? Okay. At what level does the aorta and the IVC bifurcate?
sir, L2, L3.
Huh? L2, L3, don't you
Sir,
think that's high?
I don't know exactly.
Yes. What bifurcates lower, aorta or IVC?
Sir, IVC.
Yes. So IVC bifurcates at the level of L4, L5. And if it's a thin patient, okay, and not with this thing, the vessels might come more closer to the sacral promontory. So you will not get the anterior, you will not get a good chunk of the anterior longitudinal ligament. Even when you want to fix the tape to the anterior longitudinal ligament, they might press on the IVC at that point of time. The IVC might be the common iliacs might just be there, and the tape might press on it, and that could cause a whole set of other problems.
Yes, sir.
Yes, go ahead.
What about the complications of Shirodka sling?
There can be injury to the colon, ureter, the vessels, and genitofemoral nerve injury can be there. There is
Where does the ureter injure? The easiest question. And do you go above or below the ureter?
The ureter is
and
like
above,
MS.
go above the ureter.
Okay.
Which ureter?
Right or left? Rashi, is it right ureter which is likely to be damaged or the left one? And why?
You read about the Shirodka sling?
Yes, sir.
So I was asking you a very simple question. Which is the ureter which is likely to be damaged?
I don't remember.
Okay. Why is that saw sling hitch done? Any idea?
So the source loop is made and the tape is passed in between that because there is a sigmoid colon there. The tape should not obstruct the sigmoid colon. That's why it is passed through the source loop.
So the sling passes below the sigmoid colon or above the sigmoid?
Below the sigmoid lesion, sigmoid colon's lesion.
Okay.
What are the other sling surgeries you know of apart from Shirodkar's, Purandra's?
Any other surgeries?
Which is easier? A combination of both.
Vircho's composite sling surgery. In this, on the left, on the right side, the mesh, the tape is attached to the it is attached to the anterior longitudinal ligament. Then pass to right side to the pass to the broad ligament attached to the posterior aspect of the isthmus, and on the left side, just like in Purandare's cervicoplexy, it is attached to the rectus sheath. And along with it, left uterosacral ligament is plicated to correct the dextrorotation of the uterus, which occurs in this cell.
And what are the other types of sling surgeries apart from this? Have you heard about Khanna's sling
surgery?
Yeah.
Yes, ma'am. Khanna's sling surgery. In this, the tape is attached to the posterior part of the isthmus and laterally through the internal inguinal ring, then attached to the anterior superior iliac spine.
Okay. And what about Joshi's sling?
Joshi's sling, the tape is attached to the cervix above the internal os and to both pectineal ligaments.
Okay, so which one is better of all the slings? Which is better and which has in this patient of yours? Which one would you prefer if you were an expert?
I would.
And why?
Still like to.
I think we are running late. We're running behind the schedule.
Okay.
So I like
one last question. Can you do a unilateral sling?
Yes, sir. So Navada's sling surgery is one of the unilateral slings in which the tape is attached to the uterosacral posteriorly, and both ends from the right side are attached to the anterior longitudinal ligament.
Okay.
One just thing that you can think of, since we are running short of time, if you were to do a hysterectomy or following any of the conservative surgeries, whether you're good enough to do it with the vaginal route as Sarogi sir would be, or abdominal route, then what are the things that you have to keep in mind for each of the surgeries. So for all the postgraduates, I think if you don't, one, you have to know about the conservative surgeries at the postgraduate level. Also, if you have got through the conservative surgeries and you've got through all of it, the next question is, then what happens in long-term sequelae, or if the patient requires a hysterectomy at some later point of time? And if you're doing it abdominally or vaginally, how would you tackle it for each of those surgeries? So this is something that you can think of in your spare time. Thank you. Thank you, everyone.
Can I speak for about 20 seconds?
Yes, sir. Your time starts now.
Yeah, okay. The thing is, I just want to summarize and say your history should be very brief, as Dr. Sarogi said. You have to be very clear in your presentation, the precise positive findings which are there on your history. Similarly, absolute positive findings which are there in your examination. And second, what would be your approach? I mean, you cannot have an approach, I would like to do this, that. What precise surgery you want or you think would be beneficial for this particular patient? I'm talking of surgery. It could be a conservative approach or any other approach for your particular patient. Should be a proper approach when you go for an examination. Am I right, sir?
Couldn't agree more, sir. Niranjan sir, you have raised a very valid point, and Dr. Saraugi also raised a very important issue that when presenting the case, they become so thorough and so comprehensive. They try to be. They don't understand the fallout of this is the examiner can drag you to any possible direction. It is always wise to practice your presentation 3 or 4 times before the examiner arrives in the scene. Another point I have always mentioned is that when your presentation happens, the examiner has taken away the sheet from you. So you have to say it extempo. This is very, very important that you, while writing the history and doing the examination, you remember the only salient points and present this to the examiner. This presentation is an art. And this 3 or 4 minutes that the student gets from the examiner is invaluable time. And that creates a long-lasting impression in the examiner's mind. And probably that's the reason why this is known as a long case. I think the presentation is the art which we have to develop in our students, and very importantly, sticking to the case and picking up points that are relevant to this particular case instead of being generalized. These are the skills that we have to transfer to our students. Thank you very much, sir, for raising these vital issues.
Ashish, I would like to comment that at UG level, we try to find out what student knows. At PG level, we try to find out what student doesn't know.
Yeah, that's the reason. Yeah. So I think that there need to be certain, protocol, or rather a kind of sample presentation for the postgraduates is very essential, and they should develop this technique time and again by rehearsing and repeating themselves within themselves. So I think the more this kind of practice we do, more they will learn the technique of presentation.
Right.
Thank you so much. Thank you so much,
Thank
sir.
you so much.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thanks a lot to all the examiners for chairing the session. Thanks a lot, Dr. Rashi, for presenting the case. We move on to our next session. Next session is a short case presentation on uterovaginal prolapse in an old patient. The presenter is Dr. Rucha Chaudhary. Can we have the CVs of the next examiners? Presenter is Dr. Rucha Chaudhary. She's a third-year resident from Lokmanya Tilak Medical College and Sayan Hospital. Our first examiner for this short case is Dr. Michelle Fonseca. She's my head of the unit and she's a professor in Lokmanya Tilak Medical College. I have had the privilege of working with madam for the last 7 years. She's an undergraduate and postgraduate teacher for the last 20 years. She's in charge of the PPTCT Center at Sayan Hospital, has more than 50 publications in national and international journal. Our next examiner is Dr. Shailesh Kore. Sir is also one of the most popular teachers in Sayan Hospital and Nair Hospital. Sir is presently a professor and unit chief at Nair Hospital. He has an experience of around 26 years for being an UG undergraduate and a postgraduate examiner. Sir has more than 80 publications in national and international journals. And is the office bearer of MOGS. Sir is a librarian. He's an ex-chairperson of the Genetics and Fetal Medicine Committee and has won more than 30 awards, prizes, and fellowships for research work and paper presentation. Our next examiner is Dr. Ganpat Sawant. Sir is the ex-head of the department of D.Y. Patil Medical College, Navi Mumbai. Sir is the director of Noble and Noble Plus Hospital, Ghatkopar, Mumbai, and the ex-president of Ghatkopar Medical Association. Sir is also the committee member of MOGS and IAG and has passed his undergraduation and post-graduation from the prestigious St. GS Medical College in KEM Hospital. Our last examiner for today is Dr. Pradnya Supe. She's a very dear friend of mine and an assistant professor at Sion Hospital. She's the member of the Managing Youth MOGS Youth Council, a joint assistant secretary of the JOGI, and an MUHS recognized undergraduate and a postgraduate teacher, and a facilitator of SNEHA. Okay. Dr. Rucha, can we have your case?
Yes, ma'am. Am I audible?
Yes. Sapan, can you share the screen and show her case?
Yes, I'll share it.
Yes, ma'am. Thank you so much. Did I leave the meeting?
Yes, I have shared, madam.
Good afternoon, everyone. I'm here to present a short case on uterovaginal prolapse. 65-year-old para-4 living for home delivery, postmenopausal since 20 years, female came with chief complaint of something coming out per vaginum since 2 years, which was reducible on its own, increasing on straining and coughing. She also complained of foul-smelling discharge per vaginum since 2 months. She has history of COPD, chronic cough since 10 years. Next slide, please.
Hello.
Yes, sir.
So, whatever you have said here, she's complaining only for 2 years and menopausal since 20 years, gravida 4, para 4. So, is there some disparity in the history, or you feel this is what prolapse started only 2 years back?
So she probably missed the initial stages of the prolapse, and she realized only 2 years ago when the prolapse was significant, sir.
So probably she missed when she was immediate postmenopausal. She missed means how can prolapse be missed? Or she developed a new prolapse.
So it was probably smaller in size before, and then
it gradually increased.
Yes, gradually increased because.
Okay, go ahead.
What must be the cause of foul-smelling discharge, you said, suddenly?
Sir, actually on examination, her cervix was hypertrophied and it was congested. And there was discharge coming out from the cervix, sir, because it was the third degree UV descent. So probably because of the congestion, she developed an infection over there. Because of poor hygiene also.
So which cervix is to take care better? The line which is outside or the line which is inside?
Sorry, sir?
You said there's an infection on the cervix, no? Hypertrophy.
Yes,
so if it's lying outside, it will be better to take a hygiene because she can wash it properly.
Yes, so but it is exposed to a lot of environmental conditions.
So like our hand is also exposed, face is also exposed. I just want common sense answers, nothing else. Because when we don't know the history or we don't know anything else beyond what you say. So my point is, logically, how can you put all these things together? Is it because of walking, there is a rubbing of the cervix or the prolapse which has given ulcers and got infected? Or is a primary infection giving rise to foul smell? And within the last 2 years, it's difficult to progress to this level. So in fact, you can change your history appropriately if it is required, so that these questions may not come up in your final case. You can go ahead, please.
Okay, sir. Yes, sir. Sir, on examination, patient is averagely built, vitally stable. Examination was done in dorsal lithotomy position. Per abdomen, sir, it was soft, no guarding, rigidity or tenderness. On per speculum examination, on straining, sir, there was grade 3 uterine prolapse, hypertrophied congested cervix with foul-smelling cervical discharge. No ulcerative lesions were noted. The cervical length was 1 inch, uterocervical length of 4.5 inches. So the vagina was healthy. There was also an associated grade 2 cystocele and grade 1 rectocele with no evidence of enterocele.
Is it possible that patient does not have any ulcerative lesion and still she have a very foul-smelling cervical discharge?
So she did not have a decubitus ulcer.
What is the
So it was not a
decubitus ulcer?
well-defined ulcer, sir. So it was not a well-defined ulcer. The decubitus ulcer would.
Then why she should have a foul-smelling discharge? Where is the infection? If the mucosa is intact, why she should have a foul-smelling discharge? If there is an infection, normally you will expect some ulceration and infection.
Yes, sir. So
You say there is no well-defined ulcer. So there is an ill-defined ulcer? Or there is no ulcer?
What do you think? Is it a uterovaginal prolapse or a vagino-uterine prolapse?
It is most likely a vagino-uterine prolapse.
Why? What is the difference?
A uterovaginal prolapse is most often seen in nulliparous patients where the main pathology is in the uterus, which is not accompanied by cystocele or rectocele. But in multiparous patients, multiparous patients with history of the obstetric trauma causes defects in the fascia, which gives rise to rectocele and rectocele and causes the vagino-uterine defects.
Okay, go ahead.
On per vaginal examination, the uterus was atrophied, retroverted, bilateral fornices were free and non-tender. So my impression was 65-year-old postmenopausal multiparous woman with third grade UV descent, grade 2 cystocele.
How you know that uterus is atrophic? The cervix is hypertrophied, but the uterus is atrophic.
Plus, you have said here cervical length 1 inch, uterocervical length 4.5. Totally becomes 5.5 inch.
So it cannot be a hypertrophic uterus. Your examination and what you are saying is contradictory.
What is the normal uterocervical length?
The 3 to 3.5 inches.
So here it is total uterocervical has become 5.5.
Yes, sir.
And plus you said it is a hypertrophic congested cervix and the cervical length you have said it is 1 inch, which is normal. So which is again a contradictory finding.
Okay, sir.
Go ahead.
When you are talking and making your case, as Dr. Kanpat Sawan said, you have to see that what you are talking and what your findings are correlated. Otherwise you will come in trouble while presenting the case.
Yes, sir.
Okay, go ahead.
Just wanted to know where did Rucha get this from? The links. Is she referring to the ultrasound finding or a clinical finding?
No, sir. It was a clinical finding.
Okay. So you measured it, isn't it? 4.5 inches and 1 inches.
Yes, sir.
Okay.
In short, basically, when you present, we are not going to check in detail, but whatever you said, it should match, properly. I mean, the findings and what you say. So you do that way. I mean, who's going to counter check unless patient is there in front of us? Most of the time here, there's no question. So you could have modified in such a way that it fits correctly. Because we have to reach diagnosis, we have to reach treatment, we have to reach advances, and then you go out, isn't it? Go ahead.
Plus, you have said only grade 2 cystocele and grade 1 rectocele, which is again normally in multiparous old woman, cystocele and rectocele is more pronounced when there is a third degree prolapse. Okay, so your findings, as Dr. Sawan said, should correlate. Go ahead.
So for this patient, so should I go ahead with the management for this patient?
If you have finished your history, go ahead with the management.
So for this patient, I'd like to first give her a course. I'll like to first reduce the cervical discharge, give her a course of IV antibiotics activity. give her vaginal packing, and once the cervical discharge and hypertrophy has settled, I would like to plan this patient and take her up for a vaginal hysterectomy with anterior colporrhaphy and posterior colpoperineuraphy, sir.
Rucha, isn't
Yes,
it customary that your case presentation with a provisional diagnosis, isn't it?
I'm so sorry, sir.
Always need to know that.
So that was the thing I was asking you, whether your case presentation is over. After the examination, you have to give your diagnosis or give a summary and then start with the investigations and treatment.
And the management question is, the examiners will always ask you the management. You don't jump to the management.
Yes.
That is the problem for you, okay?
Yes, sir.
Yeah. So come to the diagnosis, if you have your presentation or a summary, and then you wait for the questions.
With third degree uterine.
You are not audible, Rucha.
Ma'am, is this better?
Yeah.
Ma'am, my impression is 65-year-old multi-paris postmenopausal women with third degree UV descent with cystorectocele.
Why you feel it is not a procedentia?
So I could not palpate the fundus of the uterus outside the introitus. Hence, it was only third degree UV descent.
Have you done a POPQ measurements and classification?
Yes, sir. The next slide was POPQ.
Okay. So
measurement.
Next slide, please.
Can you move to the next slide, please?
According to the POPQ classification, it was a stage 3 prolapse, sir.
Don't take such a big pause. You go ahead.
You have only 10 minutes in your actual
Go ahead. Please continue.
So for this 65-year-old multi-para postmenopausal women with third degree uterine prolapse and cystorectocele, stage 3 prolapse on POPQ classification, sir.
What is the distance between a posterior fourchette and a perineum or anus in your patient?
It was 1.5 centimeter. Hello?
Yeah, we can hear you.
It was 1.5 centimeters, sir.
Fair enough. Please go ahead. No, continue. Go ahead, please.
Okay. Now, what is the next? You have packed the vagina. The edema is now decreased.
How did she pack? I mean,
Yes, sir, I will like.
Patient is admitted or patient is at
Yes,
home?
sir. I will endorse this patient, sir. I will endorse this. So if the patient is compliant enough and willing to do it at home, then she can pack the vagina at home. If not, I will like to endorse this patient. Send a.
Hello, Rucha.
Rucha? Hello.
Hello.
Rucha, you are not audible. I think she's logged out.
Rucha, you're not audible.
Rucha, unmute yourself.
Hello.
Yeah, talk.
Yes. So sorry, is basically
Yes,
asking you how will you pack and will you admit the patient or will you call her on an outpatient basis?
Ma'am, ideally, I would like to give vaginal packing for this patient twice daily basis. Hello.
Yes, we can hear you.
Ma'am. On twice daily basis. Yeah, I would like to by using glycerine and by soaking a uterine tamponade in glycerine solution, which by hygroscopic action will cause reduction of the edema of the hypertrophic cervix. Ideally, I would like to do this bi-weekly and give her IV antibiotics according to culture sensitivity to reduce the infection, and then post her up after pre-anesthetic workup for vaginal hysterectomy with anterior with AP repair, ma'am.
Is cancer cervix common in such patients? You said it is a foul-smelling discharge, some ulceration is there.
Yeah, would you like to take a pap smear for her?
Yes, ma'am.
Or
I
you
would
will
like
directly
to
operate the patient on vaginal hysterectomy?
Sir, I'd like to work her up before posting her for vaginal hysterectomy. Along with the culture sensitivity, I'll take a pap smear report for this patient. And if possible, also an endometrial biopsy.
The pap smear you will take after when the infection.
No, why would you take an endometrial biopsy?
What other biopsy would you be more interested in rather than the endometrial biopsy?
Ma'am, a cervical biopsy. I'll prefer cervical biopsy will be better. And I'll first take a pap smear, then I'll like to do a colposcopic examination of this patient to look for areas of high suspicion so that I can take a cervical biopsy from those areas preferably.
Patient will run away. First pap smear, then colposcopy, then biopsy. Then there'll be plus packing, IV antibiotic. Patient at home, how she will take IV antibiotic, and why IV antibiotic?
So if I'm enduring her, I would give her IV antibiotics. If she's compliant enough and willing to do the dressing at home, she can be started on oral antibiotics as well.
Okay.
What are the problems associated when you do pack the vagina? What can happen?
How many patients have you packed so far?
We packed, sir, around 7-8 patients definitely we packed, sir. Not this year, but in the past 2 years.
So
they
what are the
generally
problems?
complain of
What are the
discomfort
difficulties?
or they expel out the uterine tamponade. So
Very
it is very
good.
difficult for the uterine tamponade to stay in place for the desired time.
Absolutely correct. Very good. So how to avoid that? Because if it's a 3rd-degree prolapse, the moment she starts walking, it will come out.
Yes, sir.
Can you give her a pad?
Yes,
Can you
ma'am. We can ask her to wear a tight pad.
Yeah, so that will keep the
tamponade in place. Yes, ma'am. Okay, ma'am.
Yeah. So now you're posting her for a vaginal hysterectomy. Yeah. And you want to open the anterior pouch. But for some reason, when you take the incision when you start dissecting, you get a gush of fluid. What will you think of?
I'll like to check the integrity of the bladder wall, ma'am.
What could be the various options? What could be the cause of the gush of fluid? You're right. One could be the bladder. You have accidentally opened the bladder while dissecting. Anything else? Have you done any vaginas?
Yes, ma'am. I've done a few.
So do you infiltrate?
Yes, ma'am. We infiltrate. If I've infiltrated, if I've opened the wrong plane, I could probably get the gush of fluid.
And you get a peritoneal fluid sometimes. When you have correctly opened the anterior pouch.
Yeah. Yes, sir. Okay, sir.
Mute one device.
Sorry, sir.
I think now we have to finish it fast. We are already 4:45. We're supposed to finish at 4:15. So we are running half an hour late. So I think...
Sir is saying finish fast because there is a gush of fluid has come out. So what is the next procedure?
So you have confirmed that you have not opened the bladder. How you are going to go ahead with your surgery?
Sir, if I've opened my A pouch, then I like to open the P pouch and go ahead with transfixing the applying clamps, sir, and deliver the uterus.
How? See, Rucha, you are answering in a case presentation. You can't just tell us you're applying clamps. You have to be more descriptive.
Yes, ma'am. Yes, ma'am. I'll After opening the A pouch, I like to open the P pouch. Then I'll feel for the uterosacrals. First, I'll take bilateral uterosacrals, transfix them. Then I'll ligate the. Then I'll like to ligate bilateral uterine arteries. Then I'll like to take bilateral cornuals, ma'am. After which I'll deliver the uterus. And after checking hemostasis, I'll like to do vault closure and like to do high suspension of the vault.
Okay, so you have finished the hysterectomy. So this is a post-menopausal atrophic uterus. So what are the difficulties you face in an atrophic uterus as compared to a hysterectomy in a patient who is 40-year-old? Comparison between the two. Difficulties in a post-menopausal atrophic uterus. Is there any difficulty or there is no difficulty? Or is it more simpler?
I'm not sure about it. I'm sorry.
Okay, uterus is very small, no? You may not get 3 pedicles also. It will be very small. If the uterus is really small, then in 1 or 2 pedicles only uterus will be out sometimes. It's very fine. And plus it's a friable uterus. Very atrophic
Do
uterus.
something to improve the planes? Pre-op, can you do something so that you'll get better planes?
Ma'am, we generally like to do hydrodissection before opening the anterior and posterior pouches.
No. When the patient is in the ward, before you operate her, at the stage when you're planning to pack her and all that, can you do something to improve her epithelium, her atrophic epithelium?
We can give her vaginal creams for local vaginal cream. Estrogen creams, ma'am. Estrogen cream for local application, so that the epithelium becomes better, especially for postmenopausal hypoestrogenic women.
That's right. Yeah.
Why you want to improve the epithelium?
Sir, in general, the blood supply and the bleed.
Increase the blood supply or decrease the blood supply? If you want to increase the blood supply, why you want to increase the blood supply? Hello?
Yes, sir. So for
What is the
better,
reason? What is the reason why you want to make
so we get
vagina?
the hypoestrogenic vagina will. So it is very difficult to dissect such vaginas and operate these people, patients. So for better delineation of the planes, we would like to give her estrogen creams locally.
So we should use it in all the patients. The planes will be very simple then to dissect. Anything else? For healing? Anything? Say something.
In your exam, just don't take such a big pause. You have only 10 minutes.
I'm sorry,
Keep
I
on talking,
can't think of other things.
Well, I think since last 10 minutes, Dr. Nayak is saying, Dr. Shailesh is saying 10 minutes, the never-ending 10 minutes. So let us now wind up the short case now. And I would like to say that I think one question I expected that whether you should remove the ovaries or not. What would be your answer? What will you say, Rucha?
So she's postmenopausal, though salpingo-oophorectomy via vaginal route is difficult. So
She's a 3rd-degree prolapse, no? Still, will you be able to remove it or no? And which are the patients where the ovaries should be removed? That was, I think, Dr. Ashish is asking.
And more than that, we are not asking technical difficulty.
Yeah.
The question is whether you want to remove or no. Technical difficulty, considering vaginal surgeons are best in India, they will be able to remove it. Question is what is your decision to remove or not to remove?
So your answer should not be like that, that it is easier to remove the ovaries in abdominal operations and difficult to remove in vaginal operation. That is not the answer. The answer is whether you would like to remove it or not. Okay. So with that, I think we will end the this here, isn't it? Dear examiners, what do you say, suggest? Dr.
As an
Ganpat?
examiner, I will say basically don't present whatever is given to you. You see, you manipulate, and you make it real, feel it a real case. You think about yourself, because you are saying uterus is atrophic and here it is 5.5 inches. Plus, most of the time, what we expect is all logical answers. We have never asked anything difficult.
Yeah.
Plus, you must know the basics, the high funda. If you don't know, it's okay. Say, for example, in this patient's packing, glycerin, active whatever, it's practical difficulties, IV antibiotics, pap smear, biopsy, colposcopy, DNC. We are not asking you to enumerate what are the things to be done to diagnose the malignancy. You have to apply a mind. See, what are you suspecting and what you want to do in a minimum cost in a shorter period. That is what our logic, our thinking as an expert will come in. And then basically we have to go to the proper management, and short and sweet time patient should be treated logically. And whatever you are confident of management, give that confident management to the patient rather than what is written in journals or someone else has said in the conference. If you can deliver something good result by your own confidence, do it. I think that's the best thing. Thank you.
Thank you, Ganpat, for summarizing this entire thing. Now, today, our coordinator, Dr. Arun Naik, hasn't spoken a word also beyond the initial introduction. I would like to take taking the whole class today, and then I will come to the elaborately famous vaginal surgeon, Professor P.C. Mahapatra. I agree with Ganpat that India is very rich in vaginal surgeons. Perhaps the richest of them, one of the richest, is Professor P.C. Mahapatra. I will take his concluding remark and then close it. First of all, Dr. Arun Naik, please.
Yeah, I think what Ganpat said, everybody should remember that in exams, examiners are not your enemies. They don't want to fail you. In fact, most of the examiners want the candidates to pass. And keep your eyes and ear open, because many times the examiners give you hint. The candidate should pick up the hint and then proceed. Shailesh mentioned that you can't give such a long pause. No, if you don't know the answer, it's better to say, I don't know the answer and move ahead so that the next question can come. You can't waste your time by just keeping mum. So, few things you have to remember. I think Rucha will require a lot of reading and preparation, because the questions which were asked were absolutely practical questions, and everybody should know the answers for such practical questions. Nevertheless, I think this was a very good experience for the students, and a lot of people will know what questions are expected in exams, and I think they will get better prepared when actually they are going ahead with the exam preparations. So, Ashish, thank you very much for this wonderful effort. And let us hear from Dr. P.C. Mahapatra. At the same time, I'll take this opportunity to thank my co-conveners, Dr. Dipali and Dr. Madhuri. Both of them have taken a lot of effort in preparing this program at a short notice. And also, I take this opportunity to thank all the faculties, the chairpersons, and Dr. Rashi and Dr. Rucha, who presented the cases.
And all
Dr. P.C. Mahapatra, sir.
All the examiners, we are very thankful because they haven't taken a single rupee for honorarium. This is very, very important point from the view of the examiners. We are very grateful to you, sir, all of you. And I believe that this is a learning experience for us teachers also. We learn many things from each other. Actually, we learn silently. Nobody questions us. The students don't dare question us. But we learn many things from these deliberations and these examinations, interactions, etc. Dr. P.C. Mahapatra, would you like to conclude this? A famous vaginal surgeon of India. Is he there? Sapan, could you verify that Dr. PC Mahapatra is there or not? If
I'll
he's not,
just check, sir. Just a minute, sir. Just a minute.
if he's not there, then we will close it with vote of thanks to all of you. And it gives me immense pleasure in organizing these things. And I am at the receiving end of many experiences all over the country. So I am exposed to various, it's a wide difference and diversities of the case presentation. They are tackling the examination, the examiner's point of view, the student's point of view. But I can say one thing: if I was the student, I would have also suffered the same thing, butterflies in my stomach, like the today's students have. So nothing has changed in the examination system, and we have
Sir,
to.
PC sir is not there, sir. PC sir is not there.
Okay, in that case, so I thank you, all of you. My respectful regards to all the teachers and my best wishes to all the students who have appeared. Thank you very much, Professor Naik, and all your team. With your team, thank you very much for your nice support. And we loved organizing this as much as you also loved performing in it. Thank you so much. See you next time. Bye bye.
Thank you, Ashish. Thank you.
Thank you.
Thank you, sir. Thank you, madam.
Thank you.